have 157 slides, which is very extensive. I am going to be very brief about the content that I'm reviewing. Just also, this is stuff that you should have covered in your lecture class. And the slides have a really good layout of everything that you would need to know. And on some of the slides, honestly, I would just be reviewing what is exactly on the slide. So again, I'm just going to hit some of those core topics and need to know topics, and then move on. I also have some practice questions throughout my class. You will see that they are kind of repeat questions that I've pulled either from your ATI or your textbook. With this one, I focused on those ATI questions. So depending on how quick you are to respond to those, I might have to just quickly share what the answer is and move on just so we can get through all of that information. So just bear with me. This is the first time that we have done an ATI review class. So I just put this together this quarter. I would love to get your guys' feedback. And if you could let me know if this was helpful for your ATI via just emailing me, please let me know. That way I know if I should continue to do this for other individuals or other classes, okay? All right, questions before I dive in. We have an awesome turnout, so that makes me happy. All right, well, I am Brittany. For those of you that don't know me, I teach mental health lecture. I do mental health sims. I also teach maternal child, and I do sims. So those are kind of my two core content areas. Let's first start about hospitalizations and understanding the differences between those different hospitalizations. So there are voluntary admissions, there are involuntary, and then there's emergency commitments, okay? So your voluntary admissions are going to be those patients that decide they want treatment, okay? So they go to the hospital and they say, hey, I feel like I need some help. I'm here. I would like to get some help. So ideally, they could sign out at any time if they want to discontinue the care. The only time that they would not be able to is if during that voluntary admission, they admitted to wanting to harm themselves or wanting to harm others. And because of that, then that provider could ask the courts to have it become an involuntary commitment, okay? So an involuntary commitment is made where the court decides that this patient has to receive care. They have to go to a locked psychiatric facility to receive that care. So in order for an involuntary commitment to be placed, one of these three things has to be met. They're either a danger to themselves, a danger to others, or they're not able to take care of their basic needs. That there has to be at least one of those, you guys, in order for an involuntary commitment to be ruled in. Now, for those individuals that maybe come to your emergency room and they are psychotic or have really heavy psychosis, and you are worried about, say, their danger to themselves, what you could do or what that provider could do is an emergency commitment or a hold, okay? It's like a 72-hour hold that we place on that patient, and then we can keep them at the hospital during that time, and we'll get a court hearing scheduled within that 72 hours to review that patient's case to decide, is this something that we need to identify or rule in, I should say, as an involuntary commitment or not? Does it meet any of these three things to where we should rule that this patient does require care? And then from there, they will decide on the time frame of what that hospitalization will look like. They'll review their history, how many previous hospitalizations they've had in the past. They'll look at legal, if they've had any legal issues or breaking the law. So all of those variables will come into play in deciding what, or the length of that involuntary commitment. Okay. Questions on that at all? All right. Ethical principles. Be familiar with your ethical principles. Know the differences between them. Beneficence, quality of doing good. Okay. So the example given there is when a nurse helps a newly admitted client who has a psychotic disorder feel safe in the environment at the mental health facility. So we are trying to make that patient feel comfortable. That is beneficence. Autonomy, letting the clients make their own decisions. Okay. But that client also needs to accept consequences of those decisions. So an example there is rather than giving advice to a client who has difficulty making decisions, a nurse helps the client explore all alternatives and arrive at a choice. So that is where we are using those therapeutic communication techniques, right? And we avoid giving advice. Yet we want them to explore those options. So we kind of guide them into identifying what those other options are and list out the pros and cons to each one of those options. And then the patient can make that decision. So that is autonomy. Justice, fair and equal treatment for all. So the example there, during a treatment team meeting, a nurse leads a discussion regarding whether or not two clients who broke the same facility rule were treated equally. So making sure that we are consistent with, like, if patients do break the rules, that we treat them both the same if the same rule was broken. Fidelity, loyalty and faithfulness to the client and to one's duty. So the example there is a client asks a nurse to be present when they talk to their guardian for the first time in a year. And the nurse remains with that client during that interaction. Veracity, honesty when dealing with a client. So the example there is a client states, "You and that other staff member were talking about me, weren't you?" The nurse then will truthfully reply and say, "Yeah, we were discussing ways to help you relate to other clients in a more positive way." So making sure that if a patient does approach us and we were talking to a provider about them or another nurse, that we are honest with telling them, like, "Yes, I was just checking with the doctor to see what time he would like to meet with you." So just letting them know that, otherwise you're going to break that trust that you've been trying to build with that patient. Confidentiality. So remember that the HIPAA privacy does also, we need to consider that when we're working with our mental health patients. So we should never be talking about client information in public places. Remember in situations where if you observe a brand new nurse talking about a patient in an area or a space that they shouldn't be, first approach them and say, "Hey, I know you're new, but you can't be talking about this. Like that's you're breaking confidentiality. That's against the rules." So the first step you're going to take is trying to educate them and let them know. Now, if that same nurse you found doing it again, speaking, breaking HIPAA, then you would probably want to let your nurse manager know and say, "Hey, this is the second time. I've already kind of had this conversation with her, so you need to talk to her." Okay. So really, really important that we remember that. The only times that we can break that confidentiality or that HIPAA is with, it says duty to duty to warn is what it should say, and protect third parties, as well as reporting any like child or vulnerable adult abuse. So any cases to where we're concerned about their well-being, those are things that we would need to report as well. Duty to warn. So if a patient makes a threat against another person, we are responsible for letting that person know that our patient has made a threat against them. So again, those are situations where it's okay to break that HIPAA because we're trying to protect others in those situations. Questions at all on that? Okay. Clients' rights. So they have the right to treatment and care. Okay. So even if they come back to the emergency room over and over and over, maybe they're a patient that's homeless, also has a mental health disorder. And, I hate the term, but a lot of ER nurses, they'll say, "Oh, here comes our frequent flyer, Harold again." So, and then the care that they provide is almost lacking because it's this vicious cycle of him coming in maybe every 2 weeks. So they're not doing as thorough of a history on that patient. And that's where we have to be careful because we could miss something and it could be a big deal this time. Maybe he's having, symptoms of a cardio or an MI, some cardiovascular issues. And because of his psychosis, we're just like, oh, he's just being psychotic right now. It's nothing. It's not a concern. Well, we could literally miss some cardiovascular issues going on and he could lose his life if we don't manage it properly. So making sure that we are doing thorough histories even and really doing a complete assessment on patients, even if they do frequently come in. It's really, really important that we don't miss those things. Remembering that our patients have the right to vote, okay? Even when they have a mental health condition, they still have the right to vote. So making sure that we think about those things and offer the ability for our patients to be able to do those things. Informed consent and the right to refuse treatment, okay? So all of the patients that go into a mental health facility, they still need to sign a consent form for all of their medications. Patients still can refuse treatment, even in situations where they're Jarvised. They can refuse oral medications. However, then that nurse is going to approach them and say, yes, you can refuse these orals, but you are Jarvised. You are court ordered to receive your medications. And because of that, I will need to give you an IM injection if you continue to refuse your orals. So I would like to give you the option again. Would you like your orals or would you like me to assist with giving you an IM injection? So even though they refuse their oral treatments, unfortunately for those that are Jarvis, they would still need their IM injection, okay? So just I try to make that as clear as possible because I know that those Jarvis orders can make things really confusing sometimes. They should be participating in their plan of care. So if we're making a treatment plan for them, they should be agreeing with that. They should be present and they should be helping us identify what they should be working on. Other things that we need to think about. I'm just trying to read through your slide to see if I want to highlight anything. Okay. Seclusion, restraints, and things like that. Remember that every patient, we need to think about the least invasive, okay, and the least restrictive. So we should be trying to talk with them first, try their coping skills first, offering PRN medications, things like that, prior to jumping to like a seclusion or restraint with patients. Everyone's entitled to have those lesser restrictive measures in place first before we move on to things like seclusion and restraint. And that kind of brings me to this next slide. So this is like a federal state policy as well as facility policies that we have to follow. We could lose our license if we don't follow these. So it is really, really important. Remember, restraints can also be considered chemical if we are using medications. For instance, a patient might get like a B52, we call it. So that is where it's Benadryl, Haldol, and Ativan. And it's an IM injection that we would give them to help kind of settle their system if they are very psychotic and very aggressive. So that would be a chemical restraint. Now, other restraints would be things like your restraint chairs or your Velcro restraints. Seclusion would be just kind of putting them in like a lot of places might have like a padded room for just like a less stimulated environment, which might be able to calm that patient down more too. So things that we need to try before that, as I said earlier, is verbal interactions, trying to redirect them, providing a calm, quiet environment, or offering a PRN medication. So again, we should never use seclusion or restraint if it's like just because it's convenient for the staff or punishment of a client or somebody that's like excessively unstable or that can't tolerate that decreased stimulation. Okay. So the only times that we should really be utilizing seclusion or restraint is when we're worried about that patient harming themselves or harming others. Those are the like main times that we should be using seclusion or restraint. Questions on these at all? Okay. So this is further information on your seclusion and restraints. And you can see here how we need to have an order in place. The times need to match on those orders. That is really, really important. So if your restraint or seclusion started at 1:21 p.m., your order needs to read 1:21 p.m. You can see here that there are time limits depending on your patient's age. So the time limits for seclusion and restraints for 18 years and older is 4 hours. Ages 9 through 17 is 2. Age 8 years or younger is 1. Okay. So if they go beyond that time frame, that provider needs to meet with that patient face to face, and they would have to either rewrite the prescription or the order if that's what they would like to do to maintain that seclusion or restraint, and continue to do that if they go past that time limit. During the time that they are in those seclusion or restraints, we need to be assessing them. So we are doing their vitals. We are doing circulation checks. We are documenting their behavior. We are offering foods and fluid. We're monitoring them for pain. So documentation of those kind of checks that we're doing need to be done every 15 to 30 minutes. So you can see here all the different things that we need to incorporate in our documentation. We want to know what the precipitating events and behavior of that client was prior to that seclusion or restraint. What was the trigger? It needs to be specific, okay? So it needs to kind of tell the story. We don't want some broad statement in there. Did they get a phone call from their family member and that family member told them that they lost one of their best friends? Maybe their best friends had passed away. That is a very specific, detailed explanation as to what caused that behavior. So making sure it is specific. You need to document those alternative actions that you took. What were those kind of like lesser interventions of like verbal interactions, redirection, PRNs? What did you use, okay, to show like, hey, I attempted this, this, and this, and it was ineffective. Again, the times. So when did that restraint start? And then also you need to have that provider put in an order when they get released. How is their behavior during the restraint process? Were they shouting obscenities at staff, or were they actually starting to mellow out and you were able to have a conversation with them? If you did offer foods and fluid, you need to document that. If you gave medications at all, you need to document the time, the route, the name, and the dose of that medication. You also need to document your vital signs and when you check for CMS, because remember, if they're in a Velcro chair or Velcro restraints, then they could have those restraints too tight, which could impact their circulation to their extremities. So we do want to make sure that we're doing a thorough assessment of those different extremities that are kind of like Velcroed down or tightly secured within that restraint chair. Okay. Questions on documentation at all and rules with seclusion and restraints? Okay. Let's talk about torts. So torts are kind of that civil wrongdoing, okay, where monetary damages are going to be awarded to the plaintiff and collected from the defendant. So in a lot of time, like a lot of the situations where you might get questions related to this, I just want you to think about a patient and a nurse, okay? So the plaintiff or the injured party, I want you to think about the patient. And then the responsible party would be the nurse, okay? So there are times where a nurse may intentionally harm a patient or unintentionally harm a patient. Intentionally is where we literally go out of our way to like violate the client's rights. So that could be like I have used the example in the past of, say there's a patient that really annoys us or really frustrates us, and we just reach our breaking point, and they have a favorite book of, and that's like the only book they have with them in the hospital, and we decide to go and rip it up because we've just had it with them. That is an intentional tort. Okay. False imprisonment. That is an intentional tort where we can't just like choose to put someone in seclusion because we feel like it or it makes our job easier. Assault. So if we threaten a patient or we're being threatening to a patient, that is an intentional tort that we can get in a lot of trouble with. And then battery, touching in a harmful or offensive way. Now, your ATI also talks about giving injections against will. Careful with that. So this is more so in their explanation. They are saying if you are frustrated with, say, a client named Joe, okay? Joe is really frustrating, but he's always compliant with taking his meds. And because you're so frustrated with Joe, he's due for his medications, and you just force an IM injection on him because you know he doesn't like needles, even though Joe would be taking his orals, like he never refuses. It's a situation like that. It's not talking about like emergency meds or Jarvis's. Okay. So just make sure that you understand that. Now, those unintentional torts, you guys, this is where we're not purposefully trying to harm our patient, but maybe we didn't meet our assignment duties and it ended up in that patient getting hurt. For instance, if you were assigned a frequent observation and you were supposed to be monitoring a patient every like 15 minutes or less, and you got distracted and you weren't doing your checks, and that patient did get severely harmed, that would be an unintentional tort, okay? Because it was a failure for us to meet our duty. So those are the examples that I want you to think about when we're talking about torts and intentional versus unintentional. So hopefully that helps clear that up. Any questions on that? Okay, I do have some practice questions. Again, we'll have to do these pretty quick just so we can get through everything. A nurse in an emergency mental health facility is caring for a group of clients. The nurse should identify that which of the following clients requires a temporary emergency admission. Yes, the answer to this one is C, okay? A client who has borderline personality disorder and assaulted a homeless man with a metal rod. The reason why it's C is because this is something that tells us that he is harmful to others at this point, right? And this is in present time. Some people think it's B, a client who has manifestations of depression and attempted suicide a year ago. Well, the reason why it is not B is because suicide it's not telling us that he has current suicidal ideation. This was a year ago, so it's not currently present, okay? Yes, he has manifestations of depression, but we can't just assume that that means that he's suicidal. So the correct answer then would be C because this is the most present. Hopefully that makes sense. Next question. A nurse decides to put a client who has a psychotic disorder in seclusion overnight because the unit is very short-staffed and the client frequently fights with other clients. The nurse's actions are an example of which of the following torts? Good. Yes, this one is false imprisonment. Okay. A client tells the nurse, don't tell anyone, but I hid a sharp knife under my mattress in order to protect myself from my roommate, who is always threatening me. Which of the following actions should the nurse take? Yes. This one would be C. We have to follow those ethical principles and be honest with him and just let him know, like, hey, here's the situation. I do need to report this just because of the health and safety of everyone. Okay, good. A nurse is caring for a client who is in mechanical restraints. Which of the following statements should the nurse include in the documentation? Okay, let's talk about this one a little bit because I am seeing kind of some differing responses here. So client was offered 8 ounces of water every hour. That is one of the interventions that we need to be instilling when somebody's in restraint. So that would be incorporated in our charting. Okay. Client shouted obscenities at assistive personnel. That is behavior that was witnessed during that time of seclusion or restraint. So technically, that should be incorporated in the paperwork. Client received, sorry, it's really small on my screen, chlorpromazine, 15 milligrams by mouth at 1000. That is about medications. It has all the right information in there. So that would be a correct answer. Now, E, that is very broad. Okay. So we don't like broad statements. It needs to be more specific to like what led up to them behaving that way. And that doesn't really tell us much. Also, A, that has nothing to do with our seclusion and restraint. It doesn't matter that they ate all of their breakfast. We would still need to offer food and fluids to them. So hopefully that helps. Questions on that one? Okay. A nurse hears a newly licensed nurse discussing a client's hallucinations in the hallway with another nurse. Which of the following actions should the nurse take first? Good. This one is B. We're going to first approach her and say, hey, this is not okay. You need to stop discussing this. And then remember, if it happened again, then we would notify the nurse manager. Okay, good. Communication. Know the differences between intrapersonal and interpersonal. So intrapersonal is a conversation that we have with ourselves, okay? And it's kind of like that self-talk that happens in our heads. So it's not like us talking to ourselves really out loud, but this is where we kind of have this ability to like be like, okay, Brittany, you're going to meet with a schizophrenia patient. How are you feeling about this patient? Do you have any like biases present that could like impact my relationship with this patient? So I kind of just go through that process to help me understand how I'm feeling before I actually go and meet a patient. So that way I can set everything aside and just like remember that this person in front of me is a brand new patient. I don't have any history with this patient, and I need to kind of start off with like that fresh foundation with this new patient. Now, interpersonal communication is one-on-one communication. So this is where we would have like a one-on-one interaction with a patient. So just know the differences between those and that you're paying attention to whether a question has interpersonal in it or intrapersonal in it, okay? Again, with your communication, think about the things that we should be encompassing when talking with patients. We need to be short, simple, and to the point, okay? Make sure that we pick the right time and that it's relevant to the conversation that we're having with our patients. Thinking about the things that might keep that patient from being able to be attentive to the conversation. Well, if they're experiencing pain, we probably want to get that pain under control before we're trying to educate or have a deep conversation with them. Pacing, so the rate of your speech. So depending on their diagnosis, remember, for instance, depressed patients, it might take them a little bit more to process information. So therefore, if we're talking really quickly, they might not be able to, pick up everything that we're trying to talk with them about. So understanding that and applying, that to your time with your patient. So, okay, this patient has been really depressed. It's likely that some of that cognitive ability has slowed down a little bit. So I need to slow down my pace of speech so they can understand what I'm trying to say. So making sure that we think of those things. Your tone of voice, intonation. So making sure that it's congruent and that you're kind of using an appropriate intonation or tone of voice when you're speaking with your patients. Those nonverbals. So you need to think about all those nonverbals and what that means when you bring them to one of your interactions, and also think about cultural considerations. These are things like your eye contact, your facial expressions, your posture. So sitting with an open posture, leaning in towards others, all those are going to be kind of like your active listening skills too. Eye contact, depending on their cultural background, is direct full eye contact appropriate or not? So being able to identify those things and apply them to our conversations that we're having with our patients is really important. Again, therapeutic communication is huge, and it's something that we need to think about when we're working with all patients, not just mental health patients, but all patients. So making sure that we are attentive to the client's thoughts, their feelings, their concerns, their needs. Make sure that we express that empathy and that we're truly being genuine and we're concerned for them and want to help them. Making sure that we give time to the patient to give us information, and then also be able to try to give feedback. Again, feedback in those ways of using those therapeutic communication techniques, avoiding giving advice and things like that. Evaluating their progress towards our goals and outcomes. We'll do that on a regular basis with our mental health patients. And then making sure that we are thinking about, all those nursing processes that come into play, and that we're collaborating with the other team members to make sure that we are doing a thorough job taking care of our patients. Again, here you can see some of those essential components to therapeutic communication: giving enough time, making sure that we're thinking about our body language, our vocal quality, our eye contact, having a caring attitude, being honest, showing trust, empathy, non-judgmental attitude. So all of those things are going to help us establish that rapport and build that connection with our patients so we can have that appropriate professional relationship. So really, really important to encompass those things. Considerations. So when working with children, make sure that you're using simple language that they're going to understand. Children pick up on nonverbal messages even more than adults. So being really aware of how our body language is. Thinking about incorporating play into interactions depending on what age level of children you're working with, and also thinking about their developmental level so we can apply things to that scenario or help them and we're meeting them at their level. Adolescents. So how do they perceive their diagnosis? Are they aware of how that has impacted them? Also, think about with older clients, do they have hearing aids? Do they have glasses? Making sure that if they do have those things, that they have them with them when we're meeting with them. Allowing plenty of time for those patients. Make sure that we're sitting facing those patients, because some of them might even watch our lip movement to also pick up what we're trying to share. So just some things to keep in mind. When you are working through that planning stage, remember that we do want to provide privacy. We want to try to minimize those distractions. Again, that patient should be working with us to develop those goals and what they want to work on. And then we need to make sure that we give plenty of time for them to actually be able to meet those goals as well. And then under your implementation section, just remember establishing those trusting relationships is really important. And then we do want to make sure that we are providing those empathetic responses and explanations to the client when we're discussing with them and bringing up observations, providing hope, humor, and information. And trying our best to create an environment that will allow them to focus on themselves. So some communication techniques. At times, silence is going to be very effective, okay? Especially if a patient is kind of working through something. Sometimes giving silence, but like leaning in towards that patient to show that we are being attentive will help them even further assess like why they're feeling the way they are and kind of reflecting on previous statements. So can be a really, really good therapeutic strategy. Active listening, think about those components of active listening that we talked about before, sitting squarely, facing towards the patient, kind of leaning in towards that patient. All of those things show that you are actively listening to your patient. When you are asking questions, think about how you want to ask those questions. What kind of response are you going to want to get from the patient? So that's where you need to identify is open-ended questions or closed-ended questions the way that I want to go with the information that I'm trying to collect. More often than not, you're going to want to try to ask those open-ended questions. Giving information. So this helps provide details to the client in order to help them make a decision. So we're not giving advice, but we're just giving information to help them get to that point of being able to identify what their options are and evaluating those options. Presenting reality. This is when we are trying to help bring patients back to the present time. Okay, so this would be for people that might be experiencing delusions, hallucinations, or faulty beliefs. So making sure that we are encompassing those things for those type of patients. Summarizing is huge. We should always be doing that, I feel like, with our patients. So at the end, we can summarize or just like kind of review everything that that patient has gone over for us, because that tells that patient that we were paying attention that entire time that they were talking. Thinking about your clarifying techniques. Those are going to be things like you're restating, you're reflecting, paraphrasing, and exploring. Again, be familiar with those. They are going to come up on your ATI. Offering general leads and broad opening statements, showing acceptance and recognition, focusing. So that's going to help the client concentrate on what's important and help us retain more information from them on a specific topic. Offering self, that is kind of that ability to, or that technique that we can use to say like, hey, I'm here. I want to spend time with you. I want to try to help you. So that's going to show how we're trying to be genuine and we care for them and we are here to truly help them and guide them in being successful on meeting those goals. And then just think about therapeutic touch. Sometimes that can be appropriate, other times it cannot be. So you kind of have to read the situation to identify what is or is not appropriate. For instance, just slightly touching someone's hand might show empathy, but other times people might read that as inappropriate. So you do have to kind of read each situation and identify if that is appropriate or not. Think about your barriers to communication. So that is giving advice, giving that false reassurance, minimizing feelings, changing the topic, asking why questions, excessive questioning, or giving approval or disapproval. Lots of different things can be barriers. So we do have to identify those or be able to identify those in different scenarios. Okay. All right, question time again. A charge nurse is conducting a class on therapeutic communication with a group of newly licensed nurses. Which of the following aspects of communication should the nurse identify as a component of verbal communication? Which of the following aspects of communication should the nurse identify as a component of verbal communication? Okay, yes. This one is intonation, okay? Because all the other ones are regarding what? That's nonverbal.
Nonverbal.
Yep, you got it, Courtney. So really read your question and make sure that you are paying attention to whether it's asking verbal or nonverbal, okay? A nurse in an acute mental health facility is communicating with a client. The client states, "I can't sleep. I stay up all night." The nurse responds, "You are having difficulty sleeping." Which of the following therapeutic communication techniques is the nurse demonstrating? This one is also D, restating, okay? Again, if you're not feeling comfortable with those, I encourage you to review those different techniques again. A nurse is communicating with a client who was admitted for treatment of a substance use disorder. Which of the following communication techniques should the nurse identify as a barrier to therapeutic communication? Yes, that one is A. Good job. A nurse caring for a client who has anorexia nervosa. Which of the following examples demonstrates the nurse's use of interpersonal communication? Interpersonal. This one is actually C. Remember, this is kind of that one-to-one interaction that a nurse would be having with the patient. So in this instance, the nurse asking the client about personal body image perception would be the correct answer. Now, if the question was asking about intrapersonal communication, then the answer would be B, right? Because then that would be the nurse examining their own feelings about that. So again, make sure that you're looking at the question, interpersonal or is it intra? So the correct answer to this question, because it's asking interpersonal, is C. Okay. Let's talk a little bit about cognitive disorders. So you can see here that these are the different neurocognitive disorders recognized and defined by that DSM-5. So you have delirium, you have mild neurocognitive disorder, and major neurocognitive disorder, which is also going to be known as your dementia. Be familiar with delirium. That is that short-term and reversible. Mild neurocognitive disorders may or may not progress to major disorders. Major disorders are progressive and irreversible. Okay. So the big thing with your delirium is it like comes on quickly and it is reversible and it is short term. Major disorders, progressive and irreversible. Major and mild subtypes are further classified. So you can see there, they also talk about the Alzheimer's disease. That is neurodegenerative. And that is going to result in the gradual impairment of cognitive functioning. So that is the most common type of major neurocognitive disorder. It is really important to identify cognitive disorders and other mental health disorders because they can have similar manifestations, such as depression in older adults, that can mimic the early stages of Alzheimer's disease. So we do want to make sure that we are assessing for both depression as well as Alzheimer's in those conditions. Okay. I really liked this comparison, this image of delirium versus dementia to help you identify the differences. Again, remember that delirium has a rapid onset over a short period of time, usually like hours to days. Whereas something like a neurocognitive disorder is going to have a gradual deterioration of function over months to years. Also, your delirium often worsens at night and early mornings, whereas dementia impairments don't change throughout the day. Delirium patients often have altered level of consciousness, and it can rapidly fluctuate, where the level of consciousness with dementia is kind of more on the normal aspect and unchanged. So just be really familiar with those differences there. I'm not going to go over this step by step, but it is really important to kind of have a good idea of the progression of Alzheimer's and like what symptoms we would see based off of which stage they're in. So I did kind of highlight some of those red areas that I feel like are more prominent to pay attention to. For instance, in that stage 1, you don't really have much for memory decline, okay? But stage 2, they'll maybe start to lose things or forget names of people. Maintaining organizations with lists and a structured routine helps them to try to compensate for some of those lags that they're experiencing. Your mild cognitive decline, they really have difficulty recalling names or words. They do have a decline in the ability to plan and organize. Stage 4, they're forgetting like major events and personal history. They're experiencing the inability to like perform those day-to-day tasks. They might not be able to understand like current news events. So those are some things that you would see in that stage 4. Stage 5 is when they start to really lose that ability to engage in those activities of daily living. So they might need assistance now with hygiene and dressing and grooming. So stage 5, it's getting pretty significant. That's stage 6. They're unable to recall the name of their spouse or may even identify people. They cannot do any of their ADLs without assistance. They might have some voiding accidents or fecal incontinence. They also might be experiencing in stage 6 that wandering obsessiveness, agitation, and aggression. And then stage 7 is when they're pretty much confined to a bed and they're aphasic. Late stages, think about like during these later stages that caregiver has to be like they're experiencing role strain. And so they need a break too. So it is really important for us as nurses to remind those caregivers to do things for themselves and take a break for themselves. There's a lot of like day programs that they could try to enroll their spouse or family member in to help them get that time to themselves too, because that's really, really important. Again, this is information on supporting the caregivers. So they could seek legal counsel regarding advanced directives, determine teaching needs for the family. Again, reviewing those resources that might be available to them. Maybe thinking long-term care options or home care or like those the older adult daycare programs. Lots of different things out there that we could provide them to help them kind of make those decisions, and just making sure that we are providing as much support to them as we are the patient. All cognitive disorders, this just covers the nursing care. We do want to, especially with delirium, just try our best to minimize the risk factors and promote early detection. So timely recognition is really important with those delirium episodes. Also, make sure that we are focused on protecting the client from injury, as well as trying to promote client dignity and quality of life at the same time, which can be a tricky balance. We want to think about safe and therapeutic environments. So make sure that we don't have any tripping hazards that could lead to falls. Thinking about things to avoid wandering. For instance, having like larger signs on the doors of reminding patients where the bathroom is or where their room is can be helpful. Making sure that we have lights on at the appropriate times and a good amount of light where it doesn't like cast shadows and things like that. So that way they don't have illusions or anything along those lines. Making sure that we have them in a room with windows so they can kind of orient to the time of day a little bit more effectively. Having them wear identification bracelets and have those monitors and bed alarms on so we can be alerted if they get up at all. We only want to use restraints again as that last resort method, okay? Because ideally that could cause even more issues. So trying our best to use other methods first. Other things is that cognitive support. So again, memory aids like bigger clocks, calendars, photographs would be really helpful. Keeping a daily routine for them and giving them like a large layout of what that day is going to look like will also help. Making sure that we try to keep it consistent to the caregivers that are providing care to these individuals. Cover or remove mirrors to decrease fear and agitation. That's something that we might encompass with these cognitive disorders. Encouraging physical activity and again, adequate lighting. Physical needs. So making sure that we're assessing skin integrity and thinking about, when they do have those incontinence episodes, we do want to make sure that we are cleaning them up and doing proper cares and assessing for any skin breakdown. Monitoring them, their vital signs, looking for any tachycardia, elevated blood pressure, sweating, dilated pupils, all of that can be associated with delirium. Know your symptoms of delirium. Implement measures to promote sleep. Other things is making sure that they have their assistive devices. For instance, like if they walk with a walker or cane, do they have hearing aids? Do they have glasses? Making sure that they have those things available to them and they're placed in a spot that's very obvious to the patient. Question time again. A nurse in a long-term care facility is caring for a client who has major neurocognitive disorder and attempts to wander out of the building. The client states, "I have to get home." Which of the following statements should the nurse make? Yeah, this one would be D. You want to reorient them to like, hey, I am your nurse. Let's walk you back to your room. So D would be the correct response. A home health nurse is making a visit to a client who has Alzheimer's disease to assess the home for safety. Which of the following suggestions should the nurse make to decrease the client's risk for injury? This one would be A, D, and E. Okay, because we're trying to mitigate risk as much as possible and avoid that patient from having any harm come to them in the home. So A, D, and E. A nurse is making a home visit to a client who is in the late stage of Alzheimer's disease. The client's partner, who is the primary caregiver, wishes to discuss concerns about the client's nutrition and the stress of providing care. Which of the following actions should the nurse take? This one is C. That is correct. Offering some of those resources, such as like an adult daycare program that families can utilize to help offload them from taking care of their loved ones and give them a little bit of that break, right? Good. A nurse is performing an admission assessment for a client who has delirium related to an acute urinary tract infection. Which of the following findings should the nurse expect? Delirium. So for delirium, this one would be hallucinations as well as restlessness, okay, for delirium. So again, if that one's tricky for you, I would suggest kind of looking over the differences between your different neurocognitive disorders and what you would find with each one. All right, we're going to jump into anxiety disorders now. Anxiety disorders, those are going to be things like your separation anxiety disorder, where a person feels excessive fear when they are separated from a certain individual. Specific phobias, so that's going to be things like your zoophobia, your acrophobia, your monophobia. Agoraphobia, that is extreme fear of certain places where the client feels vulnerable or unsafe. Social anxiety disorder or social phobia, that is where they have excessive fear related to social or performance situations. Your panic disorder is when people experience those recurrent panic attacks. And then you have your generalized anxiety disorder, where a patient has uncontrollable excessive worry for at least 6 months. Okay, that is key for that one. So manifestations of panic disorder and generalized or general anxiety disorder. So panic disorder, just know that usually panic attacks typically last 15 to 30 minutes. They do need 4 or more of those following manifestations in this list here to be specifically identified as like a panic attack and fit into this diagnosis of panic disorder. So you can see here, there are a lot of symptoms. And you can also see how these symptoms are closely related to symptoms that somebody could be experiencing when having a heart attack or having a pulmonary embolism. So really important to rule those things out when we see these symptoms emerge. The client may also have really bad anxious feelings about when the next panic attack is going to occur. So it's helpful for them to learn those coping skills and be able to try to get their mind off of that, because even though they're not having a panic disorder at that time, they're fixated on when the next one's going to come, which therefore increases their general kind of anxiety on a day-to-day basis. Generalized anxiety disorder is, again, that excessive worry for the majority of days over at least 6 months, okay? And it's causing significant impairment in their ability to keep their job or social relationships or any area of functioning, essentially. The manifestations are listed on your slide here. So those are the things that we would want to look for and to identify in order to diagnose or rule in that generalized anxiety disorder. It's going to be things like your restlessness, your muscle tension, avoidance of activities or events, increased time or effort to prepare for stressful activities or events, procrastination and decision making, so the inability to make decisions, as well as sleep disturbances. Specific disorders. So there's acute stress disorder, there's post-traumatic stress disorder, and there's adjustment disorder. So acute stress disorder is exposure to traumatic events, which causes anxiety, detachment, and other manifestations about the event for at least 3 days, but not more than 1 month. So it's less. There's not time, like I want you to look at the time component for acute stress disorder versus PTSD. And you can see with acute stress disorder, the time frame is very different. And that's like the main difference between the two of them. is that this one's for at least 3 days, but not longer than a month. Whereas PTSD has those symptoms of anxiety, detachment, and other manifestations about the event for longer than 1 month following the event. And those symptoms can last for years, okay? Adjustment disorder, that is going to be a stressor, triggers a reaction, causing changes in mood or dysfunction and performing usual activities. So the stressor and effects are less severe than with ASD or PTSD. So when you're thinking of adjustment disorder, I want you to think about certain situations like a child who is having a big change in their life due to their family getting divorced. That can lead to adjustment disorder, okay? So those are the things that I want you to think about in relation to how to differentiate between those three. Then let's talk a little bit about PTSD. So the PTSD is those intrusive findings where you're going to have like memories, flashbacks, dreams about the traumatic event. Memories of the event happen involuntary, so you don't have control over it, and it's very distressing to the patient. Flashbacks can be associated with, for instance, like people that were in the military. And it can be so real to them that it feels like they're back in like a combat situation. Even with like hearing just a noise go off, maybe it was like a lawnmower that was trying to get started and kind of like just abruptly made a loud noise. And that could trigger that patient to kind of think back to a noise they heard when they were in the war. Nighttime dreams related to the traumatic event or nightmares, and also avoidance of certain people, places, events, or situations that could bring them back to that traumatic event. Mood and cognitive alterations. So a lot of the times we might see some anxiety or depressive disorders. They could be angry and irritable, decrease in activities. They could have kind of negative self-beliefs. You'll see your cognitive distortions play into this to where they have thoughts of like, I am responsible for everything bad that happens. So trying to break those cognitive distortions that they have. They can also experience dissociative manifestations. So that's that derealization and depersonalization. Derealization, I want you to think about Alice in Wonderland being surrounded by, when she eats her cake or she drinks the potion to make herself big and small, and objects around her will either be big or small depending on what she takes. That's what I think of with derealization. Depersonalization, it's like an out of the body experience, okay? So think of somebody that is almost like the soul of their body comes out and they're looking down at them, in a given situation. So out of body experience, think depersonalization, think Alice in Wonderland with derealization. Behavioral manifestations, again, are going to be things like that irritability, that aggression. They could be hypervigilant, have really hard time focusing on getting tasks done because they're just not able to have that focus. Sleep disturbances, big one is insomnia, okay? And then they could also have destructive behaviors such as like suicidal thoughts or homicidal thoughts, thoughts of wanting to harm others. Usually PTSD, you guys, is precipitated by some traumatic event, either experiencing it or witnessing it, okay? Children and adolescents that have PTSD, they are likely to, again, exhibit some manifestations of anxiety, depression, phobias. So we do want to assess for any comorbidities. And also, small children can show a decrease in play or engage in play that involves aspects of the traumatic event too. So that's something else to consider when we're working with the younger population and trying to identify PTSD. Nursing care for panic and anxiety disorders. Again, make sure that we have a structured environment, even through that interview process. Again, assessing for those comorbidities, not only for the other anxiety disorders that we talked about or depression disorders, but also substance use. So making sure that we identify what other comorbidities that they have. Making sure that we do think of safety, especially during periods of crisis or when they're experiencing those severe panic disorders. We do want to think about with people that are having panic disorders, since I'm on that topic, try our best to try to remove them from a stimulated environment to a less stimulated environment if they're willing to work with you. But remember, we're not going to want to try to engage with those patients during this panic attack, right? Because they're not going to be able to hear what we have to say. They're not going to be able to focus on what we have to say. So even just standing there and being with them will help them, okay? Will help them feel like you're at least there supporting them. You can even say a small statement of, I am here, you're not alone, to let them know that you're there. But don't try to educate because they are not going to be able to focus on what you're saying at all. Wait until after that panic attack subsides, and then you could try to engage with them. So again, remaining with them during the worst of that anxiety to provide that reassurance. Make sure that we are doing our suicide risk assessments. Think about relaxation techniques that we can apply to help them manage their pain or that muscle tension or release those feelings of anxiety. So that's going to be things like your deep breathing, imagery. There's a ton of them out there. We would put on some relaxation music and try to teach them how to meditate. So it just depends on what works for your client, but exposing them to all options so they can identify what will work best for them. Other things that we want to think about is assisting them in identifying those defense mechanisms, those maladaptive responses, and we want to replace those with more adaptive responses. Again, postpone teaching until that acute episode of anxiety has subsided so they can actually focus on what you're saying. And then think about all those other resources that we can kind of bring together for that patient to help them be successful in managing their illness. Here are, again, some of those different relaxation techniques, meditation, there's guided imagery, there's breathing exercises, there's a thing called progressive muscle relaxation, and then there's physical exercise. So whether it's yoga, walking, biking, we know that exercise releases those endorphins, which therefore can lower the amount of anxiety and help promote that relaxation. So making sure that we are encouraging that as well. Other techniques would be like your cognitive reframing. So we want to kind of think about that stop thought or that thought stopping technique where if they're catching themselves in that negative thought process, they can try to catch themselves and replace those negative thoughts with positive ones. So really important to kind of catch that and also help patients understand that, yes, maybe you made some bad decisions, but that doesn't make you a bad person. So a lot of people, when they have that negative cycle, they're just like, I'm a terrible human being. And it's like, no, sometimes we just made some bad decisions, but that doesn't make us bad people. Let's just reflect on that and see how we can learn and grow from that. All right, question time again. A nurse is caring for a client who is experiencing a panic attack. Which of the following actions should the nurse take? This one is D, stay with the client and remain quiet. A nurse is assessing a client who has generalized anxiety disorder. Which of the following things should the nurse expect? Select all that apply. All right, good job, Courtney. Yes, it is A, D, and E, excessive worry for 6 months. They'll also have restlessness and sleep disturbance as well. A nurse is caring for a client who has generalized anxiety disorder and is experiencing severe anxiety. Which of the following statements or actions should the nurse make? So this one would be A. Now, of course, out of all options, this would be the best one, right? But if somebody is having severe anxiety or a panic attack and there's an option to just like wait to talk with them, that would be the best one. But in this one, there is no other option like that. So the best one out of these would be A, okay? A nurse working on an acute mental health unit is caring for a client who has post-traumatic stress disorder. Which of the following findings should the nurse expect? Select all that apply. Good. This one would be A, C, and D. Good job. Yep. All right, now we're going to move on to major depressive disorder. So major depressive disorder is that single episode or recurrent episodes of unipolar depression, okay? So the main thing is that it's not associated with mood swings, you guys. So that's the difference there between that and like, say, bipolar, right? And these episodes of this unipolar depression is resulting in a significant change in their ability to function, whether it's like social, occupational, self-care. And it's accompanied by at least 5 of these findings that are listed below for at least every day for a minimum of 2 weeks. Okay. So that's how we can meet that criteria for major depressive. Also be familiar with major depressive disorder and how it could be further specific or further classified. It could be MDD with psychotic features where a patient is experiencing things like auditory hallucinations or delusions. And you can also have postpartum onset, so postpartum depression too. So those are things that we could encompass within that diagnosis as well. There are different phases of major depression. There's acute, continuation, and maintenance. So be aware of these differences and what kind of is involved with each one. So acute phase, that is where you have a patient that has like severe symptoms, okay? This is where we are going to really want to make sure that we're assessing for that suicide risk. We're implementing safety precautions as needed. During this acute phase to really pull them out of that extreme depression, it's going to take 6 to 12 weeks. It's likely they're going to need hospitalization during this time. And our goal is trying to reduce some of those severe depressed symptoms that they're experiencing. Now, the next phase they would move to is that continuation phase, where they're slowly starting to get the ability to function again on their own. Treatment phase or treatment during this phase is usually 4 to 9 months. So during this time, we are focused on trying to come up with ways that they can prevent relapse. So we're going to educate on their illness. We're going to educate on their medication. We're going to educate on different therapy strategies that they can use. And then that maintenance phase is when they're able to kind of get back to themselves. They're not really experiencing symptoms anymore. So this phase can last for years. And our goal is to prevent them from going and having or like experiencing another depressive episode. So those are the differences between those phases. Other diagnoses would be your seasonal affective disorder. So that usually occurs in the winter times when there's less daylight. Light therapy is going to be your like main treatment option for that. There's also persistent depressive disorder. So this is a more mild form of depression. And it needs to be, they need to be experiencing symptoms for at least 2 years if they're adults and 1 year for children in order to get this diagnosis. Now, your major depressive needed 5 symptoms from that list. If you go back, needed 5 of these. Well, persistent depressive disorder only needs 3 of these, okay? So that is also the difference between those two as well. Premenstrual dysphoric disorder. That is going to be women that experience some of those symptoms during that menstrual cycle and that those phases of that menstrual cycle. So these usually occur during the luteal phase. A lot of the things that they experience are actually going to cause problems with them being able to get through their day-to-day functioning, just because the symptoms can be so severe. They can have emotional symptoms like mood swings, irritability, depression, anxiety, difficulty concentrating. And then they can also have those physical symptoms, which is like that lack of energy, overeating, changes in sleep, breast tenderness, bloating, weight gain. So the primary treatment option is going to be exercise, diet, and relaxation therapy. That is kind of what your ATI wants you to focus on. Now, there are other options for women that do struggle with that. They could come in and see a woman's health nurse practitioner or midwife, and we could talk about other options to really help them with that. But ideally, that's where we want to start, is with exercise, diet, relaxation therapy. And then there's also substance-induced depressive disorder. So that's going to be your findings of depression that are going to be associated with the use of substances or coming off of drugs or alcohol. So that is another category that the DSM recognizes. Risk factors for depression. We do know that family history plays a very strong role in that, as well as a previous history of depression. We do know that depressive disorders are twice as common in females than compared in males. We do see depression being quite common among clients over the age of 65, just because this is like a big transition for them into like the next phase of life. And sometimes that can be a really hard transition for these individuals. But we also want to remember that we need to think about assessing for early dementia as well as depression in this population, just because remember, those two can look very similar. So making sure that we're doing a thorough assessment and trying to rule out early dementia before we rule in depression. And then we do know that neurotransmitters do play a role in this as well. So your serotonin, depending on how your deficiency with that, it's going to affect your mood, your sexual behavior, your sleep cycles, your hunger, and your pain perception. Now, if it's more of a norepinephrine deficiency, then it's going to affect attention and behavior. We do know that there's other factors or neurotransmitters that can play into that too. So you can see dopamine, acetylcholine, your GABA. So we are still gathering more and more research, but because of these findings, that's why we use some of the medications that we use to try to help with that neurotransmitter disimbalance, okay? Other risk factors are going to be things like stressful life events, chronic medical conditions, again, that postpartum period, any comorbidities of like anxiety, personality disorders, eating disorders, substance use disorders. And of course, if somebody is experiencing a trauma in their life, that can lead to them developing depression as well. Again, clinical manifestations are going to be subjective. So a lot of them are going to be subjective of that lack of energy, that lack of pleasure. So your anergia and anhedonia. Anxiety, reports of sluggishness or restlessness. You can kind of have one or the other. Sometimes you might see some vegetative states. Others, you might see like an increased appetite, especially with persistent depressive disorder. Some patients might experience constipation, sleep disturbances, and somatic reports of like fatigue, GI changes, and pain. When you are doing your physical assessment, they're going to often look sad or have like a blunted affect. Usually they lack appropriate hygiene or seem like they haven't really engaged in those day-to-day cares that they should be, of kind of taking a shower, brushing their hair, changing their clothes. Again, you could see a slowing of movements or agitation where they're restless and have like pacing, or they could be finger tapping. They're really not engaging with others. They're socially isolated. And they could have a decreased verbalization, a delay in those responses, slowed speech. So we need to make sure that we're giving these patients enough time to process what we're saying and also give them enough time to respond back to us because of those delayed responses. Seasonal affective disorder. Again, that is going to be seasonal. We oftentimes see this during the winter time or even like in the fall time. So this is best treated with that light therapy. You can see that I gave you the exposure amount there. And some side effects associated with that could be like headache, nausea, agitation. Usually it's very mild and transient with that, but that is just kind of some need to know on seasonal affective disorder. Suicide. So some suicide precautions that we need to think about in regards to our environment. So make sure that when somebody is suicidal, that we do have them on that one-to-one constant supervision. So that means that they have someone with them at all times, and privacy is not something that we offer them, unfortunately, just because we are truly concerned that they might hurt themselves. So you're with them when they go to the bathroom, when they eat, when they sleep, everything. You do document while you're on that one-to-one. So if you're the staff assigned to them, you'll be documenting like every 15 minutes what you're doing with that patient. And you can see there of the different documentations that you might do of their location, their mood, if they're making certain statements. That is helpful because then when the provider looks at that documentation, that will help them identify like, okay, should we keep them on this one-to-one, or can we start maybe giving them a little bit more freedom or ability to have, some breaks from having staff constantly with them. So it's really important to write down that stuff so the provider can look at it. We always want to search clients' belongings. Honestly, you're going to do that with every single patient that comes through. If you're working at like a locked psychiatric facility, you're going to remove anything that could be used as like a weapon or, a ligature. So something that they could use to try to like hang themselves with. A lot of the times, if they are on a one-to-one, we'll only give them like plastic utensils that they can use, and then we'll count those utensils for all patients to make sure that we have all the utensils counted for. We do want to make sure that we are always seeing that patient, even their hands when they're sleeping. So oftentimes we will tell those patients that their hands need to be outside of their blanket, even when they're sleeping. So that way we know that they're not trying to harm themselves with their hands. Making sure that they swallow all their medications, making sure that we restrict visitors from bringing anything harmful to the patient as well. When we are asking questions about suicide, we always want to make sure that we're very direct with our questions. So making sure that we can also ask follow-up questions if it's not clear to us if they are thinking about suicide. Making sure that we do give time to them and we establish that rapport so they will kind of come forward to us when they are struggling. And then involve significant others in that treatment plan. Making sure that we involve the family is really, really important. Some things that we can do with them after they discharge to make sure that they stay safe is developing a contract with them to where they need to sign it. And then you can also give them information about like suicide hotlines and community resources of, community groups that might get together. But as you can see, a big one is that no suicide contract. So a lot of the times it's going to be like a written contract between the facility and the patient agreeing on some terms to help them try to also take responsibility prior to going back out into the community and transitioning to like a lesser locked facility. Okay. So just some things there on suicide to be familiar with. Again, you're teaching for antidepressants. So a lot of times we are going to use SSRIs, but there are a variety of different antidepressants out there. With all those different antidepressants, remember to tell them that they cannot just abruptly discontinue their medication, okay? They're going to have really, really icky side effects. Therapeutic effects are not immediate. It can take time, depending on which medication they are. It could be 4 weeks, it could be 6 weeks. So you do want to encourage them to keep taking that medication until they reach that full therapeutic effect. The medications can cause sedation, so avoiding hazardous activities, letting the provider and the staff know if they're having an increase in any suicidal thoughts. Remember that for children, we do see for like adolescents and children that is something that is more prominent. So we do closely, want to monitor those adolescents and children for any behaviors or clues that would tell us that they have that increase in suicidal thoughts. So some things that maybe you would want to look for would be, people writing letters to family members or giving away really important belongings to other people. So that would kind of elicit to us that maybe they were making plans and taking steps to end their life. So really, really important to talk about that with family members. Again, some of your medications that you might come across for depression would be your SSRIs. That's kind of the leading number one treatment we'll try to use. I gave you the different types there on your PowerPoint here. Other things that we need to think about with those is sexual dysfunction, monitoring for serotonin syndrome. So making sure that they're not using St. John's warts. Be familiar with what serotonin syndrome is. What are the signs and symptoms of that? Remembering to have them work with their provider if they want to stop their medication so they can titrate slowly off of that med. Again, for people that have like liver or renal dysfunction, we're going to start at a lower dose for those people and just really closely monitor them to make sure that they're not experiencing any side effects. Here is your monoamine oxidase inhibitors. We don't use these as often just because of all their different interactions they have with food and other medications. Be familiar with hypertensive crisis and what causes that. So we want to avoid those foods with tyramine. Also, we know that there's a lot of interactions that can happen with this medication. So we say absolutely no other meds, even over-the-counter meds, should be taken without talking to the provider first. Also, you want to make sure to educate these patients that they don't want to use this within 10 to 14 days before surgery too. So that's a discussion that they need to have with their provider to work out a plan to get them off of that med or start titrating down on that if they have to have a surgery. Serotonin syndrome, just be familiar with that. It can be 2 to 72 hours after starting a medication, and it can be very lethal. So I gave you some manifestations that you need to look out for that would tell you that you're experiencing or that patient is experiencing serotonin syndrome. If we see that as a nurse, we're going to want to hold that medication, okay? And we're going to want to do a quick assessment to see how they're responding or like what's their level of orientation. Then we're going to start some symptomatic treatment, which could involve medications. It could involve cooling blankets. If it's severe, it could even involve artificial ventilation. Again, St. John's warts. Just burn that into your brain. That St. John's warts, you guys, is a medication or an over-the-counter that we always want to screen for, and that it can lead to that serotonin syndrome. I guarantee you'll get something like that on your NCLEX. Your hypertensive crisis, again, that's affiliated with your MAOIs. And that is with that tyramine. So avoiding those foods. I gave you some examples of different foods that are tyramine rich. I gave you some manifestations that would also help you identify hypertensive crisis. In the case of hypertensive crisis, you'll see that you're going to want to administer a medication. You have a couple different options for that one, and we're going to watch them closely, do cardiac monitoring, and offer respiratory support as indicated for that as well. So again, just make sure that you guys are feeling good with the differences there and how you would assess or identify that those things are happening. Other depression medications include your atypical antidepressants, your tricyclic antidepressants, and your serotonin norepinephrine reuptake inhibitors. So be familiar with these different things that fall into each category. Again, I can't go over everything in here, but I'll just point out some basics. So your atypicals are going to be like your bupropion, your mirtazapine. We're going to want to monitor for hyponatremia, monitor food intake and weight due to appetite suppression, especially with your bupropion, and avoid administering if at risk for seizures with those. Tricyclic, make sure that you do a baseline ECG. We also want to talk to them about orthostatic hypotension and the anticholinergic effects as well. And again, avoid concurrent use of TCAs and MAOIs because of that severe hypertension that it can cause. And then your SNRIs are going to be like your venlafaxine, your duloxetine. Monitor again for weight loss that can decrease appetite. We do want to be cautious with those that have hypertension, and again, avoiding abrupt cessation of those. All right, we got a few more questions. A nurse is assessing a client who has major depressive disorder. The nurse should identify which of the following client statements as an overt comment about suicide. Select all that apply. This one would be A, C, and E. All of these would be considered overt, meaning the client directly talks about their perception of an outcome of death. So we'd want to further assess for a plan. B and D are what we would call covert comments, which the client identifies a problem but does not directly talk about suicide. So further assessment would be required with those statements. So the correct one would be A, C, and E. All right, next question. A nurse is caring for a client who states, I plan to commit suicide. Which of the following assessments should the nurse identify as the priority? This one would be B. Yes, you guys are correct. Good job. A nurse is caring for a client who is on suicide precautions. Which of the following interventions should the nurse include in the plan of care? This one, yep, this one would be D. Good job, you guys. Sorry, I don't mean to rush you, but we still have 100 slides to get through. So D would be the correct answer for that one. A nurse is conducting a class for a group of newly licensed nurses on caring for clients who are at risk for suicide. Which of the following information should the nurse include in the teaching? This one would also be D. Okay, D would be the correct answer for that one. A nurse is caring for a client who has major depressive disorder. Which of the following should the nurse identify as a risk factor for depression? Select all that apply. This one is B, C, D, and E. B, C, D, and E for question 1. A nurse working on an acute mental health unit is admitting a client who has major depressive disorder and comorbid anxiety disorder. Which of the following actions is a nurse's priority? Yes. So knowing that they have comorbidities, we would want to place them on a one-to-one because we would know that they have an increased risk for suicide. Good. A charge nurse is discussing the care of a client who has major depressive disorder with a newly licensed nurse. Which of the following statements by the newly licensed nurse indicates an understanding of the teaching? This one would be C. The client is at greatest risk for suicide during the first weeks of a major depressive disorder episode. Okay. So that goes back to that acute phase. So think about that acute continuation, all those different phases of depression. So C is the correct answer. A nurse is providing teaching to a client who has a new prescription for amitriptyline. Which of the following statements by the client indicates an understanding of the teaching? So this is one of those questions where you have to be familiar with what category that this medication's in. And so for this one, it would actually be B. I feel drowsy for a few weeks after starting this medication. So go back and look at amitriptyline if you got this one wrong, okay? To kind of get a better idea and understanding of the side effects associated with that and what category that drug falls into. A charge nurse is discussing mirtazapine with a newly licensed nurse. Which of the following statements by the newly licensed nurse indicates understanding? This one's tricky. So this one is actually A, just because it does have, like, it's a little different. It's not an SNRI, okay? So that's different than this one, but it still also affects the serotonin and norepinephrine. So it increases the release while your other ones, your SNRIs, if you go back, let me bring you to here. These are going to inhibit reuptake. So it's a little bit different than the SNRIs, but it still affects your serotonin and norepinephrine, even though it's under a different category. So again, it's just kind of being familiar with how these medications take action, where do they, sit in regards to like what category they fall under and the different side effects associated with it. So I know that's a lot. So if that's something that you need a refresher on, I would suggest going back there and looking at your different medications and the side effects and how they're categorized, okay? Bipolar is our next topic. I do want to take just a mini break. It's 2:45. We will come back at 2:50 to start this and kind of finish out the rest of our lecture here. We do have a lot to still get through, so I will do my best to try to kind of be straight and to the point with this material. 2:45, come back at 2:50. I'll give you guys a break to go grab something to drink or use the restroom. All right, let's jump back in and talk a little bit about bipolar disorder. So take some time to understand the differences between your bipolar 1 and your bipolar 2. Bipolar 1 client has at least one episode of mania alternating with major depression. Okay. Bipolar 2 is when they have one or more episodes of hypomania alternating with major depressive disorders. And so with bipolar 2, I want you to think of this like a med student, right? A medical student going to medical school where they can still function, they're still getting through medical school, but they go through these phases where they'll stay up for 4 days in a row studying for this big exam that they have. And then once they're done with that exam, they're going to go and crash for like 2 days and sleep for 2 days straight. So that's what I think of when I think of bipolar 2, where they still have the ability to function, right? And their hypomania isn't as severe or doesn't have as excessive of symptoms. Where bipolar 1, they have more of that euphoria, grandiose, very elevated and expansive mood. And they can even have hallucinations, delusions, and things like that. So just make sure that you feel good between the differences there. Again, just make sure that you're aware too that they do have those recurrent episodes of depression and mania. This can occur in early adulthood. Early onset is something that we could look at, or be diagnosed, and you could see it diagnosed, in pediatric patients, but it is really hard because a lot of the symptoms can be associated with like ADHD. And so it's really hard to differentiate between the two. And we just really hate to put labels on children at such a young age. So we're really cautious about making sure that we take some time to thoroughly investigate and understand the symptoms before we attach a label of a diagnosis to it. With bipolar patients, they do have periods where they can function very normally and their symptoms don't really cause much issue for them. But they can also have those episodes, again, of that when that mania hits, where they could be psychotic, paranoid, engage in bizarre behaviors. So that manic episode is what causes a huge amount of impairment for them, whether it's in their occupational functioning, their social activities, their relationships. For bipolar 1s, it does usually sometimes require that hospitalization to prevent harm to themselves or to others. Motor activity is really excessive and frenzied. So it can be very drastic for some patients. Again, here are your definitions of mania, hypomania, and rapid cycling. So your mania is that elevated mood. It can be expansive, irritable, does usually require hospitalization for those bipolar type 1 patients. Manic episodes last at least 1 week. So oftentimes I feel like the patients that I would take care of, it would be a couple weeks that they would be in that manic episode. Now, hypomania, again, is going to be less severe. It lasts at least 4 days, accompanied by 3 or more manifestations of mania. Hospitalization is usually not required for these individuals because it doesn't have as much impairment to their day-to-day lives. But keep in mind that hypomania could potentially progress to mania. And then there's rapid cycling. That's where a patient has 4 or more episodes of hypomania or acute mania within 1 year and is associated with increased recurrence rate and resistance to treatment. So if we have somebody that has had rapid cycling, it just makes it really challenging to find medications that are really effective for them. Here you can see your manic characteristics. So this is where it was saying that they need to have certain, symptoms associated with this in order to identify it as like mania or hypomania. So this is your list of those manic characteristics. And then I also put on the slide those depressive characteristics, since we do know that Bipolar is kind of fluctuating sometimes between that mania and those depressive episodes. So be familiar with the different things that you would encounter during that mania as well as during the depressive episodes. Things that we need to think about when we're taking care of patients that have bipolar is decreasing the stimulation without isolating the patient. So thinking about our day rooms, making sure that we don't have somebody blaring a radio while the TV's on, okay, while other clients are talking, because that's just increasing all the stimulation and then can escalate behaviors for other patients. Making sure that we think about kind of those lesser interventions prior to engaging in like seclusions, restraints, one-to-ones, if we do have a patient that is kind of ramping up. So making sure that we try our best to use those interventions that we talked about before, those less restrictive interventions. Other things is making sure that we find outlets for physical activity to help like get that energy out of them. Okay. So whether it's going on a walk in the courtyard and just walking laps with them over and over and over to try to just like exert some of that energy. Making sure that we're thinking about protecting their dignity during these times, because they do have poor judgment and impulsive behaviors, and they might engage in some inappropriate actions or kind of, have some indiscretions that we want to try our best to maintain their dignity. So if they're trying to remove their clothes in the day unit, oftentimes we would have sheets close by, like in the back of the nurse's station, so we could quick grab that and cover a patient if they did come out and were trying to expose themselves. Self-care needs, we need to think about making sure that they are getting enough sleep, that they're getting enough fluid and nutrition. So a lot of the times we're going to think about finger foods for these individuals, things that they can pick up and eat on the go. So that way they are able to get some nutrition in them, because they're going to have a hard time sitting down. Trying our best to encourage appropriate clothing, which can be tricky because we can't force them to change. So maybe even just like going in the morning before they wake up, and you could set the clothes that you think would be a good option for them on the bed to help kind of persuade them to put those items on. Giving step-by-step instructions for hygiene and dress might be needed during those manic episodes. Our approach to these individuals, we need to be calm, but matter of fact. Give very concise explanations. Make sure to set boundaries and limit setting. So you need to stay consistent with that too. It's really important to avoid those power struggles and make sure that we reinforce non-manipulative behaviors, because when people are manic, they can be very manipulative. And trying our best to use those therapeutic techniques that we talked about before. Dealing with patients when they're manic, it can be very challenging. So you just have to try your best to do what you can and work with your team as much as possible. So cognitive approaches can be very effective when it comes to communicating to help them kind of understand the thinking pattern they might be experiencing, and help them kind of identify that irrational versus rational. But other times, if a patient is super manic and they're really loud and they have rapid speech, then mimicking to them how you want them to speak or how you want them to talk to you. So slow down your speaking, use a quieter voice. So you're like imitating that to them. So hopefully they will kind of bring down their voice and speak more slowly. If you have patients that have a manic episode and have rapid speech, flight of ideas, where it's really hard to make sense of what they're saying, tell them that, hey, Jane, I am sorry, but I am having a tough time following you right now. Manic patients might not be suitable to join in on groups because oftentimes they can become like really interruptive and unable to concentrate and take the group off topic. So during these times, we still want to encourage them to participate in other activities, but that's the time that we could maybe get them to do those physical activities to release some of that energy. And then later we could come to them with the material that we provided the group and do like a one-to-one setting for them so they're not missing out on that, and to see if they're actually wanting to engage with us at that time. For different medications that you might come across for bipolar, your big ones are going to be your mood stabilizers. Those are first line therapy. So these are going to help kind of prevent and treat that mania and the depressive episodes. These can be really, really helpful for people that have those rapid cycling, occurrences of that mania over and over. Some of the meds that you might see are like your lithium carbonate, and also anticonvulsants. So you can see there you have your valproate, your Depakote, your carbamazepine. Those are all used to treat acute mania. Lamotrigine is used for maintenance therapy. So just know the differences between your medications with bipolar. You'll also see antipsychotics used, especially if that mania has resulted in some hallucinations. So that's where you could see your chlorpromazine and your lexapine being used. Second gens might include your olanzapine, your risperidone. You also can see Seroquel is approved to help to treat depression in your bipolar patients. And then you also have your SSRIs, like your fluoxetine, that might be incorporated to help with the major depressive episodes that these patients are experiencing as well. Lithium is one of the medications where I want you to be very familiar with it. I want you to identify some of those side effects and things that we need to pay attention to. Be on the lookout for fine hand tremors, because that is something that could also be telling us that maybe their lithium level is not where it should be. We want to talk to them about their sodium content or like their salt intake, right? So making sure that they're conscientious about that. Avoiding use of NSAIDs to prevent toxic accumulation of lithium. So you're going to want to encourage them to use things like aspirin as a mild analgesic. Also think about like renal toxicity and the things that we're going to do to monitor for that. Yeah, lots and lots of information here, you guys. So make sure that we are understanding of this stuff. Fine hand tremors can be kind of a side effect that they can experience. So one thing that they could try to use to help combat that is propranolol, but we would give them the smallest dose as possible. So that could be something that we could chat to them about too, if that was something that was problematic. Another slide on lithium toxicity. This I pulled from your ATI, so this is directly related. And you can see that I have some common adverse effects with those levels less than 1.5, early indications with levels 1.5 to 2, advanced is 2 to 2.5, and then just some of your nursing administration information to be familiar with. And I kind of starred what we would expect for levels during initial treatment of a manic episode, as well as that maintenance range as well. So please look at this, be familiar with it, because lithium toxicity is a big one to where you're going to get a lot of educational questions and medication management questions related to lithium. Another one is your carbamazepine here. This is one of those anticonvulsants. So again, I provided you with quite a bit of information on here. As you can see, a lot of these different medications are category D for pregnancy. So that is a big thing to be aware of. The other thing is like a lot of these meds are going to interfere with oral contraceptives. So that is a huge educational point, educational point that we were going to want to make and discuss with our patients. Avoiding grapefruit juice is a big one with carbamazepine as well. So again, just be very familiar with carbamazepine. Lamotrigine. Again, this is another teratogenic, so it can cause birth defects. It can also decrease the effectiveness of those oral contraceptives. You can also develop Stevens-Johnson syndrome from this. So be familiar with what that looks like. I gave you some examples on the slide. This is a medical emergency. So again, just know these symptoms that we would want to screen our patients for with that. Valproate or valproic acid. So again, avoiding these in pregnancy. Category D, again, they affect the use of oral contraceptives. You can also see some other problems that we might encounter with this, such as thrombocytopenia, pancreatitis, hepatotoxicity. So we are going to want to assess baseline liver function and monitor liver function regularly, minimum of every 2 months during the first 6 months of treatment. So make sure that you guys are feeling familiar with what we're going to do, how we're going to monitor these medications, therapeutic ranges of those different medications as well. Okay. Other education that we're going to give outside of doing medication education is just making sure that case management is doing some follow-up with the client as well as the family, incorporating those different psychotherapy, psychotherapy or psychoeducational groups for the family as well as for the individual. And then health teaching of how this is a long-term, disorder that they're going to have to maintain their medications and be on their medications to make sure that they can keep those symptoms at bay. And then also just developing coping strategies and ways to try their best to reduce those relapses and maintaining regular sleep and nutrition and how important that is, and just really making sure that they stay on top of their medications. All right, we got some more questions. Although historically lithium has been the medication of choice for mania, several others have been used with good results. Which of the following are used in treatment of bipolar disorder? Select all that apply. So this one would be A, C, and D. The physician orders lithium carbonate 600 milligrams TID for a newly diagnosed patient with bipolar 1 disorder. There is a narrow margin between the therapeutic and toxic levels of lithium. The therapeutic range for acute mania is... This question, the answer would be A. A nurse is discussing early indications of toxicity with a client who has a new prescription for lithium carbonate for bipolar disorder. And the nurse should include which of the following manifestations in the teaching. Select all that apply. So with this one, polyuria and muscle weakness, those are early signs. So B and D. It's not tinnitus because that is an indication of severe toxicity. Rash is not a sign of toxicity, and people don't get constipated. They get diarrhea when we're talking about toxicity. Question 2, a nurse is discussing routine follow-up needs with a client who has a new prescription for valproate. The nurse should inform the client of the need for routine monitoring of which of the following. So this one would be routine monitoring of liver function tests due to the risk of that hepatotoxicity. So that would be the one that you would want to select there. A nurse is caring for a client who is experiencing extreme mania due to bipolar disorder. Prior to administration of lithium carbonate, the client's lithium level is 1.2. Which of the following actions should the nurse take? The correct answer for this one would be A. A nurse is admitting a client who has a new diagnosis of bipolar disorder and is scheduled to begin lithium therapy. When collecting a medical history from the client's caregiver, which of the following statements is a priority to report to the provider? So this one would be one of the contraindications for lithium is diuretics, such as furosemide, due to the risk for toxicity. So this is going to be the greatest risk for the client, and that would be the highest priority for that one. Okay, so that's why it would be D. A nurse is planning care for a client who has bipolar disorder and is experiencing a manic episode. Which of the following interventions should the nurse include in the plan of care? Select all that apply. So this one would be B as in boy, C, and E. Okay. Offer concise explanations, establish limits, use a firm approach. 2, a nurse is teaching a newly licensed nurse about the use of ECT for the treatment of bipolar disorder. Which of the following statements by the newly licensed nurse indicates understanding? So this would be ECT is effective for clients who experience severe mania. A nurse is caring for a client who has bipolar disorder. Which of the following is the priority nursing action? We would want to monitor the client for escalating behavior. This relates to safety because when behavior escalates, that puts them more at risk for harming themselves or for harming others. A nurse is caring for a client who has bipolar disorder. The client states, I am very rich and I feel I must give my money to you. Which of the following responses should the nurse make? This one would be B. I am here to provide care. This is direct, it's concise, short and to the point, and setting that boundary. A nurse is discussing relapse prevention with a client who has bipolar disorder. Which of the following information should the nurse include in the teaching? So this one would be difficulty sleeping, participating in psychotherapy, and anhedonia are all the correct answers. So B, D, and E. It's not A just because they should avoid caffeine altogether since it can precipitate a relapse. And it's not C because they should be taking their medications regularly, not just when relapse occurs. All right, now we're going to jump into schizophrenia and other psychotic disorders. So I've listed out schizophrenia, schizotypal, schizoaffective, psychotic, and brief psychotic. So please be familiar with the differences there. As you can see, schizophrenia, the symptoms need to be present for at least 6 months. It does need to interfere with their ability to go to school or work or self-care or their interpersonal relationships. Schizotypal is impairments of personality or self and interpersonal functioning, but the impairment is not as severe as schizophrenia. Schizoaffective is when they meet the criteria for both schizophrenia as well as depression or bipolar disorder. And then your psychotic is when a patient exhibits psychotic features or bizarre behaviors, but it doesn't meet the criteria for a diagnosis otherwise specified. And then brief psychotic disorder is when a patient has psychotic manifestations that last 1 day to 1 month. So know the differences between your positive and your negative symptoms, okay? Your positive symptoms, I want you to think of the things that aren't like normally there. So that would be your hallucinations, that would be your delusions, that would be your alterations in speech and your bizarre behavior. Negative symptoms, I want you to think more like depressive symptoms or the things that should be there that aren't. So their affect, they have that poverty of thought or speech. They have that lack of energy, the lack of pleasure, avolition, lack of motivation. So make sure you know the differences between those. Other findings that we'd see outside of positive and negative would be your cognitive findings. So disordered thinking, inability to problem solve or make decisions. They have difficulty concentrating. Affective findings would be more so emotional related. So that would be like hopelessness, suicidal ideation, or rapidly changing mood for like individuals that have schizoaffective disorder. Your different alterations in thought. So be aware of the differences here. So what is ideas of reference? What is a somatic delusion? What is thought broadcasting? What is thought withdrawal? What is magical thinking? So make sure that you're feeling familiar with these different ones and you're able to categorize them. So I gave you some examples there to help you be able to understand those. The big ones are going to be your ideas of reference, your grandeur, and probably your thought processing ones, okay, of your broadcasting, insertion, withdrawal. I feel like the other ones are pretty understanding. I guess your persecution would be another one too. That's a very common one. So again, just make sure that you identify and know each one of those and what they mean or stand for. Same with your alterations in speech. Know the difference between associative looseness, word salad, flight of ideas, neologisms. What happens when you see clang association? What are you hearing from that patient? So just know what those terms mean and what that means for the patient. Know your differences between your different hallucinations. Auditory is hearing things. If they do hear voices, we need to ask them, are you hearing command hallucinations? Are you being told or instructed to do something to harm yourself or to harm others? Really, really important. Other ones would be visual or olfactory, gustatory, and tactile. So honestly, auditory and visual and tactile are probably your more common ones, but you can still come across olfactory and gustatory. Alterations in behavior. So these are some of those bizarre or odd behaviors you might see that would be part of some of the positive symptoms that you might come across. So just taking a peek or just making sure you do your thorough assessment into understanding and identifying these different alterations in behavior. I'm not going to go through these since they are nicely listed out on your slide there. So just make sure you review those. Standardized screening tools. So remember that we are doing an AIMS assessment. AIMS assessments are done to assess for tardive dyskinesia, which is an EPS symptom, and it can be permanent if we don't catch it in time. So it's irreversible. So this is things where you might have like odd face or tongue movements, like tongue protrusion, lip smacking, stiff neck, difficulty swallowing, excessive blinking. But you can also see like legs and arms like squirming and kind of doing these like weird maneuvers. You could also see rocking where someone sits and they're constantly like rocking back and forth. So those would be signs of tardive dyskinesia as well. So be familiar with why we do AIMS and what we're screening for and what tardive dyskinesia is. Myelotherapy. So making sure that, again, we're always thinking of a structured and safe environment, thinking about therapeutic communication, asking directly about hallucinations, not arguing with patients, but also showing empathy. I don't hear anything, but you do seem really frightened. Making sure that we're not arguing with patients over delusions either. Making sure that we're constantly thinking about assessing for paranoid delusions because we know paranoia can escalate and increase to violence, and we want to try to get that before it gets to the violence, the concern of them engaging in violence. Command hallucinations. We need to think, we need to think safety and keeping this patient from harming themselves or from others. So what are we going to do to help keep them safe? Likely, you're probably going to put those individuals on a one-to-one observation. Think about triggers, and reducing triggers that will cause hallucinations or certain delusions for patients. Trying to make sure that we try to keep patients reality-based as much as possible. And again, being empathetic with our communication with patients that are having or experiencing psychosis. Other things to consider is just assessing discharge needs and their ability to perform those activities of daily living, teaching those self-care activities, teaching a lot on medications, collaborating with the client of talking about not only medication, but also coping abilities, making sure that we kind of give them a relapse prevention plan to look back on those different coping strategies. Make sure that we encompass family and psychoeducational therapy to help them become a little bit more familiar with the disorder, treatment, and ways that they can support this family member that has schizophrenia. So making sure that we teach the family about their triggers or signs that, hey, your family member might be relapsing, so they can kind of get that patient to the provider to get help before it actually ends up being another rehospitalization episode. So really important to involve the family with that. Your medications, your first gens, are going to be the ones that are listed here out on the slide. These are usually used to treat those positive psychotic symptoms. Some education that we're going to give is mainly around those anticholinergic effects. You can see here some of those symptoms include like dry mouth, blurred vision, constipation, photophobia. So make sure that we are giving some advice on how they can combat some of those symptoms, okay? First generation, the first generations that we were just talking about, make sure that we are always monitoring for those EPS symptoms. So that's going to be your dystonia, your akathisia, your pseudoparkinsonism, your tardive dyskinesia. So I wrote out what acute dystonia looks like and, how this is like a rapid treatment that we need to think about. We're going to treat with benztropine. Your pseudoparkinsonism, what are the symptoms associated with that? Tardive dyskinesia, what are the symptoms associated with that? What about your neuroleptic malignant syndrome? So I definitely tried my best to break those down and help you guys identify the pertinent things that you need to know about those different EPS symptoms and what you're going to do if you come across those, okay? Other medications would be your second gens, your atypicals. So I listed those out here. I also wrote out the available forms for some of these and the kind of like things that should stand out to you for these different ones. For instance, your clozapine, you're wanting to monitor those white blood cells. You're checking for agranulosis and leukocytosis. I also listed out some advantages there and some client education that you're going to want to consider with that. The nice thing with these second gens is there's fewer EPS side effects, but that doesn't mean that they don't happen. So you still need to screen for those. We also see fewer anticholinergic effects. And some of these can also help treat both the positive and negative symptoms. So that can be very helpful for patients too. Ideally, for patients that have been non-compliant in the past, outpatient treatment could involve like IM injections. We have injections that can be provided every 4 weeks and some that are every 2 weeks. This also can avoid patients like pocketing or cheeking their medications. Meds that can be given IM or in those extended release options include your olanzapine, your Abilify, and your paliperidone. Haloperidol decanoate is another one as well. So just know which ones that are in that IM form. Keep in mind that we do need to educate on like the different medications, like risperidone. We want to educate about the increase in fluids and fiber intake because that one does sometimes have more of those anticholinergic effects. Ziprasidone, you want to educate to take that with meals, and you also want to get a baseline ECG with that as well as periodically. Olanzapine, that one, you're going to want to give education on as well. This is one of the options that we could use for for positive and negative symptoms. Again, that Clozaril, that comes with a lot of that education. It's hard on the body. They're going to want to do those regular lab works because of that agranulocytosis and leukocytosis. And risperidone is the other one that does a very good job of treating the positive and negative symptoms as well. So review that stuff a little bit more, but those are the things that I really wanted to hit on. Other health teaching, again, is going to help them understand the disorder, need for self-care to prevent relapse, medication effects, attending support groups, abstinence from alcohol and other substances, and keeping a journal to help them monitor their medication effectiveness as well. All right, questions. A nurse is completing an admission assessment for a client who has schizophrenia. Which of the following findings should the nurse document as positive symptoms? So this one would be auditory hallucinations, use of clang associations, delusion of persecution, and constantly waving arms. Question 2, a nurse is caring for a client who has substance-induced psychotic disorder and is experiencing auditory hallucinations. The client states, "The voices won't leave me alone." Which of the following statements should the nurse make? Select all that apply. So for this one, you would want to ask, when did you start hearing things? It must be scary to hear voices, and are the voices you hear telling you to harm yourself? Sorry, guys, I just really have to get through these, but for the recording, you can always pause and give yourself time to answer the questions. A nurse is caring for a client who has schizophrenia and exhibits a lack of grooming and a flat affect. The nurse should expect a prescription for which of the following medications? This one would be that risperidone, that second-gen antipsychotics. They're really effective in treating both the negative and positive symptoms of schizophrenia. Question 2, a nurse is caring for a client who takes ziprasidone. The client reports difficulty swallowing the oral medication and becomes extremely agitated with injectable administration. The nurse should contact the provider, discuss a change to which of the following medications. Select all that apply. So this one, you have to try to identify the different formulations that these medications come in. So olanzapine is available in a orally disintegrating tablet. So that would be appropriate for clients who have difficulty swallowing. The aripiprazole, that is also available in an oral disintegrating tablet. Clozapine is a disintegrating tablet, and acenapine is also a sublingual tablet. So all of those would be appropriate for that patient. A nurse is caring for a client who has schizoaffective disorder. Which of the following statements indicates the client is experiencing depersonalization? So this one would be B, I am no one and everyone is me. A nurse is caring for a client on an acute mental health unit. The client reports hearing voices that are stating, "Kill your doctor." Which of the following actions should the nurse take first? So this one would be initiating that one-to-one observation would be your priority action for that. A charge nurse is discussing manifestations of schizophrenia with a newly licensed nurse. Which of the following manifestations should the nurse identify as being effectively treated by first-generation antipsychotics? Select all that apply. So remember that your first gens are going to treat those positive symptoms, okay? So severe agitation, delusions of grandeur, and auditory hallucinations would be the correct answer. A nurse is assessing a client who is currently taking perfenazine. Which of the following findings should the nurse identify as an EPS? Select all that apply. So this would be drooling, involuntary movements, and continued pacing are all signs of EPS, okay? Not decreased level of consciousness. That is more associated with neuroleptic malignant syndrome rather than EPS. So it would not be that one, okay? A nurse is speaking with a client who has schizophrenia when the client suddenly seems to stop focusing on the nurse's questions and begins looking at the ceiling and talking to themselves. Which of the following actions should the nurse take? So with this one, remember direct questions about the hallucinations. So we would ask the client, are you seeing something on the ceiling? Okay, so 10 types of personality disorders. So know your different clusters and which personality disorder falls into which cluster, okay? So you can see here that your cluster A personality disorders are going to be more of those odd or eccentric traits. So you have your paranoid, your schizoid, your schizotypal, okay? I wrote out some significant findings to each one. So please review those. Paranoia, they're going to be constantly on guard, hypervigilant. They're tense, they're irritable, and sensitive to feelings of others. They avoid a lot of interactions with others. Your schizoid, so they won't really have a lot of personal relationships. They don't need to have those emotional ties to others. They're seen as eccentric, isolated, and lonely. So they engage with animals more than people for schizoids too. Schizotypal, they have more of like your schizophrenia symptoms of like magical thinking, behavior is odd, peculiarities in thinking. So just some of your traditional schizophrenia symptoms that are more tied with that schizotypal, okay? So again, take some time to read the differences between those. Cluster B personality disorders are going to be more of your dramatic, emotional, and erratic traits. So that's going to be like your antisocial, your borderline, your histrionic, and your narcissistic. So narcissistic, that is going to be kind of these people that are like really high on themselves, have like a high sense of self-worth. They lack humility. They're very optimistic and carefree. Antisocial, they have a lot of irresponsibility, guiltless behavior, break the laws a lot, manipulate others for personal gain, don't really hold relationships all too well. Psychopathy is another term that we use that is a synonym of antisocial. Okay. Borderline, they are going to be they're identified as intense and chaotic, unstable or instability. They have fluctuating attitudes of others. So they see things in black and white, like you're either a good or bad person. And it fluctuates too, depending on their mood. Very impulsive, self-destructive. They engage in a lot of self-harm. So we do want to be constantly monitoring for that in them. And it is twice as common in women. Histrionic, colorful, dramatic, extroverted, emotional. They engage in a lot of seductive behaviors. They use a lot of their physical appearance to draw attention to themselves. So just again, be familiar with those different ones. Cluster C, these are people that are anxious. They have like anxious or fearful traits, insecurities, inadequacy. So this is like avoidant behaviors or avoidant personality disorder, dependent, and obsessive compulsive. So avoidant, they express feelings of being unwanted. They desire close relationships, but they're so scared of rejection that they like won't try to instigate relationships, or they'll just kind of stay away because they're just so worried that people are going to reject them, even though they're just really longing for those connections. Dependent is where they lack self-confidence. They're extremely reliant on others. They have intense discomfort being alone. They are not able to really make decisions for themselves. And they're overly generous to others and avoid positions of responsibility. Obsessive is going to be people that are overly disciplined, perfectionist, preoccupied with rules, inflexible about the way that things must be done. They do have fears of making decisions just because they're worried that they're going to make a mistake. So those are the things that you would see maybe in some obsessive. Nursing care. So when we are dealing with people that have personality disorders, we want to make sure that we kind of have that intrapersonal conversation with ourselves and be aware of the things that might, from the past, like impact the way that we care for these individuals and try our best to set those things aside. Okay. Safety is always a priority, just because, like, for instance, people that have borderline personality disorder, they're going to be at a huge risk for self-injury or antisocial for violence. So making sure that we're thinking about those things and managing those things out on the unit. Communication strategies. So firm yet supportive and consistent approach is really important, okay? Limit setting and consistency are so essential for clients who are manipulative, especially borderline and antisocial personality disorders. Clients who are dependent and histrionic, they will benefit from assertiveness training and modeling as well as psychotherapy. Schizoid, schizotypal personality disorders, they tend to isolate to themselves, so the nurse should respect that to a certain degree, but still offer groups to them. Psychotherapy can really help them with that. For clients who have histrionic personality disorder, they can be very flirtatious, so it's really important to instill those professional boundaries. And then for clients who exhibit that dependent behavior, self-assess frequently for countertransference reactions in those relationships. I think the biggest challenge outside of like things on here for personality disorder is like honestly setting those consistent limits. It's really, really important to make sure all staff are consistent with those patients. Other interventions, the overall goals of therapy for individuals with personality disorders is to help them become aware of how their behavior affects their life. Medications can be encompassed with therapy. However, it's important to know that medications is not a cure-all and will not be as effective as therapy is for these individuals. So you can see here the different types of therapy that we could offer them. Dialectical behavioral therapy is a big one. That is part of like CBT therapy. And then also you'll get involved with case management. That's going to be very beneficial for those individuals and help them even when they transition back out into the community. So make sure that you're feeling familiar with those different types of therapy that we can offer those individuals. Again, here are some questions. I'm going to kind of cruise through these because we are over our time. So a nurse manager is discussing the care of a client who has a personality disorder with a newly licensed nurse. Which of the following statements by the newly licensed nurse indicates an understanding of the teaching? Pause the recording if you'd like to give yourself time to answer the question. The correct answer to this one would be C. When caring for a client who has a personality disorder, limit setting is appropriate to help prevent that client manipulation. A nurse is caring for a client who has avoidant personality disorder. Which of the following statements is expected for a client who has this type of personality disorder? The correct one would be A. Clients who have avoidant disorder often have a fear of abandonment. This type of statement is expected. A nurse is caring for a client who has borderline personality disorder. The client says, the nurse on the evening shift is always nice. You are the meanest nurse ever. The nurse should recognize the client's statement as an example of which of the following defense mechanisms. This one would be splitting. This occurs when a person is unable to see both positive and negative qualities at the same time, okay? So they see somebody as all bad one time and all good at another time. A nurse is assisting with a court-ordered evaluation of a client who has antisocial personality disorder. Which of the following findings should the nurse expect? Select all that apply. So this one would be C and E, exploitation and manipulation of others. Those are expected findings, okay? So that would be the correct answer, C and E. All right, now we're gonna jump into eating disorders. Anorexia nervosa. So this is where they are kind of decreasing their intake. They have a big fear of gaining weight or becoming fat, and they have disturbance of in self-perceived weight or shape. So a lot of the times they are preoccupied with food and the rituals of eating, along with a voluntary refusal to eat. We do see this more amongst females than males, and we do see it more in adolescence or young adulthood. This can be precipitated by a stressful life event, such as college. That can be a common one. Compared to clients with restrictive type, those who have like a binge eating or purging type, they do have higher rates of impulsivity and are more likely to abuse drugs and alcohol. So as you can see, the different types below, restricting is just basically restricting how much food you're taking in. So there's no like binge or purge. And then the binge eating purging type is where they'll take in a bunch of food and then they'll just purposely try to cause themselves to throw up. So with this, patients usually that have anorexia nervosa, their body mass index or BMI is lower than that 18.5. Okay. Again, they're going to be hyper focused on their weight and feel like if they gain weight, that their life will be over. You call that catastrophizing. Okay. So they blow their weight changes out of proportion and have blinders on, which they can't really recognize other important things in life. So just kind of be familiar with that too. I think that's all I wanted to hit with this one. Oh, other things is like oftentimes they have issues with control. So this is one thing that they do have control over. So it's really hard for them to like work through that because especially in a healthcare facility, you know, the one thing that you can choose is to have control over what you put in your body, for food at least. So that is their mechanism of being able to have still some control in that setting. Again, you can see here some of the findings with anorexia nervosa. So they are literally starving themselves. So over time, that can result in several complications. So at first, there's muscle tissue loss throughout the body. That's going to often manifest as fatigue. That can also lead to difficulty breathing, to a weak diaphragm. Even the heart can become weaker, and that can result in bradycardia. As well as hypotension, as well as orthostatic hypotension when that blood pressure falls, when a person goes from that lying down position to a standing. For women that menstruate, they will have amenorrhea, where either the normal menstrual cycle stops or menstruation doesn't occur by the age of 15. They have prolonged food restriction, as well as taking laxatives frequently, can also upset that GI tract. And then they're unable to handle normal meals, which can cause like terrible bloating, nausea, and constipation. Individuals with binge eating and purge type might also have like halitosis, or that really bad breath from vomiting. Also, the bone marrow can start shutting down because of the lack of essential nutrients. So then they'll have neutropenia, fewer white blood cells, which leads to a dampened immune system, anemia, or fewer red blood cells, which leads to lower energy levels, thrombocytopenia, fewer platelets, which can lead to easy bleeding or bruising. Anorexia can also cause osteoporosis, where the bones become weak and susceptible to fractures. The skin can become dry, scaly, brittle, or it can be covered by brittle or soft hair. This is called lanugo. It's kind of what you would see on like a newborn baby, and that's actually a strong sign of anorexia as well. It can even get to the point where it affects the brain, causing symptoms of confusion, irritability, restlessness, depression, anxiety. So people can die from this. It's pretty severe. So we do want to make sure that we are doing our best to work as best as we can with these patients, and it is a slow process. Oftentimes, hospitalization is going to be indicated when that median BMI is less than 75% of that expected for the client's age and sex, or when the patient is trying outpatient treatment and has not been able to gain the weight that they agreed upon within their contract. Treatment is going to be nutritional rehab to help restore and stabilize normal weight and eating patterns. We will incorporate some CBT therapy to kind of change their thoughts and beliefs about weight and food. If they do experience depression or anxiety, we'll treat that with antidepressants. And we also want to be really cautious about refeeding syndrome. So that is that sudden intake of large quantities of food that can cause large amounts of insulin to be released at once and cause these major electrolyte shifts. And that can actually be really life-threatening, you guys. So we do want to make sure that we are careful about that and we're not overdoing it very quickly for these individuals. The Maudsley approach is a family treatment approach. I'm not going to go over that in super specific detail, but I did lay it out on the slide if that's something that you would like to review. This can be a very effective approach for family members and the patient. So that way we can kind of work with the family as well as the patient to resolve how they're viewing, eating and how it's looked at amongst the family and the patient to really try to help them when they get back out into the community. All right, questions. A nurse is obtaining a nursing history from a client who has a new diagnosis of anorexia nervosa. Which of the following questions should the nurse include in the assessment? Select all that apply. So this one would be, what is your relationship like with your family? Would you describe your current eating habits? Can you discuss your feelings about your appearance? So all of those would be appropriate questions for this patient. A nurse is caring for an adolescent client who has anorexia nervosa with recent rapid weight loss and a current weight of 90 pounds. Which of the following statements indicates the client is experiencing the cognitive distortion of catastrophizing? So this one would be life isn't worth living. So clients' perception of their appearance or situation is much worse than their current condition. A nurse is planning care for a client who has anorexia nervosa with binge eating and purging behavior. Which of the following actions should the nurse include in the client's plan of care? This one would be D. We want to prevent purging. So we're going to put them on one-to-one observations during that mealtime. All right, bulimia nervosa. So this is where clients eat large quantities of food over a short period of time. That's considered binge eating. And then it can be followed by inappropriate compensatory behavior, such as like self-induced vomiting, which is purging, to try to rid the body of those excess calories that they just took in. Binge eating and that inappropriate compensatory behavior both occur on average of once per week for 3 months in order to meet that diagnosis. Excuse me. Usually this happens in a discrete period of time, usually less than 2 hours, and an amount of food is definitely like that they take in is a way larger than what would be anticipated for somebody to eat in that similar period of time. They have this ability to control the amount of food that they're taking in and they end up overeating. These patients will have a higher BMI, so compared to anorexia nervosa patients. So it'll either be within a normal range or even slightly higher. So you can see there that BMI is like between 18.5 to 30. Usually we will see this in late adolescence or early adulthood. Again, this usually occurs in females, and a lot of times between these binging episodes, they actually do like a caloric restriction of like the foods that they take in between these binges. Again, you can have purging type where they try to use self-induced vomiting, laxatives, diuretics, or enemas to try to lose or maintain weight, or non-purging, which they compensate for binge eating through other means, such as like excessive exercise and the use of those other things that we had mentioned earlier. Here is some of the findings that you would identify in somebody that does have that bulimia nervosa. Again, just that normal to higher BMI, their weight fluctuations, halitosis from the vomiting, enamel erosion. You could also see knuckles calloused from induced vomiting. That's called Russell's sign. And this can lead to electrolyte shifts and things like that too from that excessive vomiting, their excessive vomiting episodes. So again, just be familiar with your different findings between your anorexia nervosa and your bulimia nervosa. All right, a nurse is obtaining a nursing history from a client who has a diagnosis of anorexia nervosa. Which of the following questions would the nurse include in the assessment? Oh, we already just did this one. I apologize. So this one again would be that, what is your relationship like with your family? Would you describe your current eating habits? Can you describe your feelings about your appearance? I think we did all of those. It must have backtracked. So sorry. Here we go. A nurse is performing an admission assessment of a client who has bulimia nervosa with purging behavior. Which of the following is an expected finding? Select all that apply. So this one would be hypokalemia and slightly elevated body weight. All the rest would be associated with anorexia nervosa for this one, okay? A nurse is caring for a client who has bulimia nervosa and stopped purging behavior. The client tells the nurse about fears of gaining weight. Which of the following responses should the nurse make? So you'd want to acknowledge concerns and then refocus conversation on clients' accomplishments, which can promote that self-esteem and self-image. So that's where this one would be. I understand you have concerns about your weight, but first let's talk about your recent accomplishments to try to like get them focusing on something positive. Okay, we have quite a few much more to go. So I will try to get through this as quick as I can here. Substance-related disorders. So make sure that you are understanding the definitions of different terms. So you can see how I highlighted addiction and tolerance. So be familiar with what those mean. Be familiar with intoxication and withdrawal. So use this as a good guide to help you understand those different definitions, okay? Expected findings and admission data. So when we are trying to do an assessment on patients, we do want to collect certain information about substances. The type of substance, the pattern and frequency of use, how much are they using, when did they start using that substance, has there been an impact on their job or school performance with the use of these substances, has there been a change in the use or the pattern of use. Have they gone abstinent from using these substances? Have they had any previous withdrawal episodes from this substance? And the last time they used that substance. Also, we want to know, have they had any blackouts or loss of consciousness from the use of these substances? Changes in bowel habits, changes in weight, sleep problems, chronic pain, concern over substance use, and have they been cutting down on their consumption or behaviors? Complications associated with alcohol abuse. Be familiar with your neuropathy, with your myopathy and Wernicke's. Know the differences and the symptoms that are associated with each, okay? So I laid out those key things. A lot of conditions with alcohol is related to that thiamine, okay? That deficiency in thiamine. So be familiar with that as well. This is also some other complications you would come across with alcohol abuse, Korsakoff's psychosis, and alcoholic cardiomyopathy. So again, understand what they are, how you can prevent, or like things that you would look into, I guess, to identify what's going on, and treatment for that as well. Alcohol withdrawal manifestations. So just know that within 4 to 12 hours of cessation of or reduction in heavy and prolonged alcohol use, you can start to have withdrawal symptoms. And that would be these symptoms listed out here, okay? Physicians may prescribe, I'm not even going to try to pronounce this medication, but I have it kind of I'm circling it here, for patients experiencing alcohol withdrawal symptoms. Now, alcohol withdrawal delirium can occur 2 to 3 days after stopping alcohol use. That is considered a medical emergency. I listed out what the symptoms would be associated with that and how alcohol withdrawal delirium can progress to death. So it is a big deal. We use what's called the CWAS scale when we are working with patients that are withdrawing off of alcohol. So we can try our best to keep them from experiencing that alcohol withdrawal delirium. So we will give certain medications to help kind of manage some of those symptoms to avoid them becoming more severe. Medications for withdrawal are going to be like your benzodiazepines or that other one that was listed out on that slide prior. These are going to help alleviate some of those symptoms of like nausea and tremors. That chlordiazepoxide lessens that risk for alcohol withdrawal while the patient is receiving treatment too. You might see some anticonvulsants used, and you could also see naltrexone used to help reduce cravings. So that's going to block the brain from feeling pleasure. Medications for abstinence, that's going to be like your disulfiram, your naltrexone, and your acamprosate. I am not as familiar with that one. It helps prevent drinking because it causes really negative effects if they were to engage in drinking. It'll cause like nausea, vomiting, headaches, sweating, and flushing. And it's not a fun experience. So if patients are taking that, it will probably keep them from drinking so they're not experiencing those negative side effects. Things that we need to consider: monitoring their vitals, their neurological status, again, implementing seizure precautions. That can happen if they go into that delirium and withdrawal. We do want to educate providing to avoid drinking with that disulfiram and the education behind it, and thinking about placing patients on a one-to-one if they are experiencing some delusions or hallucinations. Opioids. So these attach to the CNS receptors, altering perception of and response to pain. This can lead to generalized CNS depression. Be aware that these are Schedule II under the Controlled Substances Act. Your different opioids are listed out: heroin, morphine, hydromorphone, as well as the different ways that they can be used. I also included effects of intoxication and your antidote, naloxone. So don't get that confused with naltrexone. Naloxone is used for toxicity or overdose of opioids. Okay, so that's a big one to remember. Withdrawal symptoms and manifestations are listed on this slide. So you can see here that it will start with kind of some sweating, rhinorrhea, goosebumps, tremors, irritability, and then all of a sudden those symptoms are going to get more severe. It's very unpleasant, but it's not life-threatening like alcohol is. And it can take, hours to several days before manifestations will occur. Some withdrawal medications would be methadone substitution. This can be kind of like a replacement for individuals that were using opioids. It's an opioid agonist, and it kind of prevents abstinence syndrome from occurring. And they use this for withdrawal and long-term maintenance, but dependence can occur to this. So you have to be careful with the use of it, and it should be tapered off, but it does block the effects from other opioids too. So that way they won't use other opioids to try to get those desired effects. Clonidine is another one that could help reduce cravings for opioid. It does not reduce cravings for opioids, but helps with withdrawal effects of nausea, diarrhea, and vomiting. Buprenorphine is another one. This can be used for withdrawal and maintenance. It does decrease feelings of cravings for that one. And again, your naltrexone is a pure opioid antagonist that will suppress the craving and pleasurable effects of opioids as well. So just be familiar with those different ones. Cocaine and amphetamine, these are going to be your stimulants. I also listed out the intoxication and withdrawal, so be familiar with those for both the amphetamines as are both amphetamine and cocaine. Nursing care. So we do want to make sure that we are thinking about safety, right? That's going to be primary focus. So preventing falls, implementing seizure precautions, close one-to-ones, orienting patients to time, place, and person, maintaining adequate nutrition and fluid balance, low stimulating environments, and administering medications as prescribed for intoxication or managing withdrawal. We're going to educate on addiction and initial treatment plans, remove prescription medications in the home and let the family know that they should be doing that, not sharing meds, develop motivation and commitment for abstinence and recovery, encourage self-responsibility, and help them develop an emergency kind of plan or a relapse prevention plan. Therapies, CBT is a big one. Relapse prevention therapy is another big one. There's your 12-step programs and family groups such as Al-Anon and Alateen. So just know with Al-Anon and Alateen, those are more family groups for the family to attend with the teen. And these will help with teaching them that abstinence is necessary for recovery. So that's a big portion of that 12-step program. You can also have group therapy in family therapy and talk about codependency with family as well to help keep that or prevent that from happening. All right, question time again. I'm going to give you a moment to read the question and then we'll go over the answer. So pause the recording here. And then your answer for this one would be fine tremors, vomiting, and restlessness. Again, pause the recording and read the question and provide your answer. And this one would be implement seizure precautions. This one would be disulfiram. Again, read your question and pause the recording. This one would be eliminating codependent behavior. Your primary goal of treatment is abstinence. So that sibling needs to discuss their personal feelings for that. So that would be this one here as well. So all of those, eliminating that codependent behavior. The primary goal of treatment is abstinence, and our sibling needs to discuss personal feelings. All of those would be the correct responses. Again, read your question and give yourself time to do the problem. The correct answer for this one would be A. The correct answer for this one would be C, D, and E. The correct answer for this one would be B, can cause dry mouth. The correct answer for this one would be avoiding eating 15 minutes prior to chewing the gum. And then this one would be the correct answer of A, B, C, and E. Okay, we're on to Module 9, Mental Health in Children and Adolescents. So let's talk about this a little bit. On this slide, I have clinical findings for conduct disorder. So you can see here that the big things would be kind of meeting the criteria for that. So be familiar with the different criteria and the aggression to people and animals, destruction of property, deceitfulness or theft, and serious violations of rules. This one does involve a lot of often bullying, intimidating others, again, harming animals, forcing like sexual activity against someone. So those would be findings that we would see with conduct disorder. We do see that more in males than females. Symptoms of ODD generally considered less severe than those with conduct disorder. We're going to be talking about oppositional defiant disorder I believe maybe a little bit in this one. If not, it will definitely be in your module review. So definitely this one can lead to more of like antisocial or the psychopathy that we had talked about earlier on when we were talking about personality disorders. Some predisposing factors are listed out on this, biological, neurobiological, psychosocial, as well as family influences. So there are quite a few factors that can play into this. So just be familiar with kind of those general factors that could kind of predispose someone to develop conduct disorder. This slide is on your attention deficit hyperactivity disorder, ADHD. So again, be familiar with the DSM criteria of how we would diagnose this, and then also those predisposing factors as well. Because you can see that some different things will play into this. A lot of those could be related to prenatal and perinatal care. So just be familiar with those different ones as well. For your treatments, I listed out on this slide your different medications that you might come across with the different names there for your medications. These are believed to elevate dopamine and norepinephrine levels to help with kind of that neurotransmitter dysregulation and do seem to be very effective. But I want you to also be aware of the side effects and that they can be commonly abused as well, especially on like college campuses. So this slide is just covering some of that information. I have a couple questions here, so please pause and take a moment to try to answer these questions. The correct answers for these would be 1 is A, B, and C, and question 2, the correct answer would be D. Assessing for abuse and violence. So we have nurses that are specifically trained for certain assessments like this. They're called forensic nurses, and they are able to collect evidence and also just really provide that trauma-informed care for these individuals. We do want to make sure that we conduct a thorough nursing history, making sure that when we do that, we provide privacy. We're direct, honest, professional. We use language that they understand. We're very understanding and attentive. And we're using those therapeutic techniques to really demonstrate that understanding and empathy to these patients that have gone through something very traumatic. Age-specific assessments, infants. So think about shaken baby syndrome. That can cause intracranial hemorrhage. So we want to assess for like respiratory distress, bulging fontanelles, an increase in head circumference. Retinal hemorrhage could also be present, or any bruising on the infant before the age of 6 months is also suspicious of like abuse or violence. To identify abuse and violence in preschoolers to adolescents, we would just want to, again, look for any unusual bruising, especially on the abdomen, back, or buttocks. Assess for mechanism of injury to kind of like help you understand the, physical features of even the bruises, can help you identify what or how these people could be injuring the child. Look for burns. So look for any signs that the child may be getting purposely burned by a support person or their caregiver. Again, fractures is a big one, bite marks, head injuries. For older and vulnerable adults, again, you're going to look for any bruises, lacerations, abrasions, fractures, to where it doesn't really match the history or like what they're saying happened to the individual. So you want to make sure that you do get like a history from both the caregiver as well as the patient to see if the stories match up too. Physical abuse. This just kind of goes over those different physical abuse forms and some signs and indicators. So again, it's kind of hitting some of those same things. Make sure that you are aware of those different signs that would tell us that somebody is being physically abused. So you can see here that I broke it down of like signs and indicators of physical abuse and physical abuse suspected when the parent or adult caregiver does these things. So if a parent is describing their child as evil or in a negative way, or has a history of abuse as a child or history of abusing animals and pets, it's likely that they could be engaging in abusing their child. So just being very alert to those different things or those different clues that could help us hone in on if a child is being abused. Neglect. So here I wrote out the definition for physical and emotional neglect, so you guys know the differences there. Indicators of neglect as well. And when, again, a parent or caregiver is kind of making these comments or is demonstrating these behaviors, that can help us determine if neglect is happening in the home. So those are things to be aware of as well. This is information on that trauma-informed care that we talked about. You can see here, it talks about the 4 R's. So realizing the widespread impact of trauma, recognizing the signs and symptoms of trauma in clients, family, staff, and others. Responds by fully integrating knowledge about trauma into policies, procedures, and practices, and resists re-traumatization. When we are screening, just be familiar that there's primary, secondary, and tertiary as well. So know the differences between those different types. And that will also help you as well if you're familiar with those different kinds. Other things is knowing your laws for where you are at and where you're practicing, because there are going to be different laws related to this, but the majority of laws that are going to stay consistent are us having the responsibility to report any suspected child or vulnerable adult abuse. There is criminal penalties that we could face if we were not to report those off and we were made aware that something was happening in the home. So just something to keep in mind. And then always help patients that have maybe encountered this in the past develop a safety plan, making sure that they are aware of their different community resources. For instance, if there's like a safe home for mothers and children in the community, make them aware of that. Make them aware of how they can contact those individuals or how they can get safety from that facility if they need to. So really, really important to know those community resources around you. Hopefully the last, we might actually have one or more topics. Crisis characteristics and types. So know your different types of crises, you guys. Is it situational? Is it maturational? Is it adventitious? Know the different characteristics. This is more kind of just understanding which one falls into what category and those characteristics. So take a look at those on the slide. This talks about the phases of crises, okay? And it's broken into those 4 different phases. So just be familiar with what is happening in each phase. This is talking about debriefing and how important it is to debrief after there's been a traumatic incident. This is just an example of like a school shooting. I believe this was an image taken out in the parking lot. So it is really, really important for everyone that was involved to go through a debriefing and make sure that it's done like right after the event has taken place. It does show, like statistics show, that if we can do immediate debriefing, then it's less likely that it will develop further into other disorders of like PTSD or anxiety and stuff like that. So this is just some more information on that, as well as early interventions that we can incorporate to make sure that we're doing what we can to prevent people struggling with those disorders. This is on client education and collaboration for family and community violence. So you have here client education and the interprofessional collaboration. So making sure that we are encompassing those things. Sorry, guys, I'm just trying to get you through here as best as I can. This is also talking about further crisis intervention and that safe house and shelter that I talked about earlier, as well as family therapy. and educating the family about different strategies to problem solve outside of using violence. So really hitting home on those different topics. All right, practice questions. So question 1, the correct answer for this one would be C. Question 2, correct answer for that one would be D. This is covering ECT therapy. So again, know your indications for ECT. A lot of it is going to be related to major depressive disorder. The next common disorders might be schizophrenia, as well as acute manic episodes with bipolar. So those are kind of the main 3 that you might be using ECT therapy for. Risks. So making sure that you do cover, well, the provider should be covering risks with those patients. Main ones are going to be kind of that short-term memory loss that is going to happen right after treatment. And we hope that that resolves back to normal after 6 months. But letting them know that that can be a common finding is really important. The role of the nurse. So we want to make sure that we are doing what we can in these different phases of care. So the main thing that I wanted to point out here is make sure that that consent form is like filed. So we're going to make sure that we just find that consent form and see that it had been signed. Otherwise, we need to notify that physician right away, and they need to make sure to have that conversation with the patient. And we could be a witness to them signing that document as well, but it needs to be in the patient's chart. Making sure that the most recent labs and results have come through for our different testing that we want to do for these patients prior to them undergoing treatment. And then we're going to make sure that we are taking their vitals, they're using the restroom, removing any like dentures and eyeglasses and things like that from the patient prior to treatment. 30 minutes before, we're going to be administering certain medications and staying with the patient to help with their fears and anxieties and try to just keep them feeling positive about the procedure as well. So just be familiar with the different things that you would do as a nurse in your role during ECT therapy. This slide is talking about more so the after treatment and the interventions, just to kind of help reorient the patient after treatment because they are going to kind of be in a woozy state. And then also some things that we should be considering for evaluation when we're assessing kind of them coming out of it. So just some things to review on that slide. I have some more practice questions here. Question 5, the correct answer would be B. Question 6, the correct answer would be C. Question 9, the correct answer would be C. Question 10, the correct answer would be D. And that is finally it. I know this was an extensive review, you guys, but I truly hope that some of this information will help you be successful on kind of guiding your studies and knowing what areas you need to focus on. Please, please let me know. I put my email here of how your test goes. I hope that this was helpful. I would love any feedback, good or bad. So don't hesitate to reach out. Please make sure you do your dynamic quizzes. That will extremely help. I've heard that trying to do all the dynamic quiz questions was really, really effective for people to try to achieve the highest score on this ATI exam. And don't hesitate to reach out to me if you have any other questions, okay? Thank you, everyone, and have a good day.